Committee Room 29. Sound. 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 Committee Room 29, 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 sound. Committee Room 29.
Public, Nuala, go ahead.
Yeah, just my volume is up max, so I can't do any more, but it's very quiet. I don't know if it's the same for everybody else, but my volume on my side is up max, but it's still very quiet. Don't know if there's something in the room that can.
Okay,
Yeah.
we will
Yeah.
try.
Message the broadcast.
We'll ask IT. I'll shout. Later, it might even just be my microphone here. So it might be. Okay, so we'll just carry on and we'll try and work on that. So can I advise the committee the meeting will be recorded and broadcast throughout Parliament buildings and also online. Members in the public gallery, just to remind everybody, welcome. Mobile devices need to be in silent, and they can connect to the assembly via Wi-Fi. Passwords there in the gallery rules, and it's not permitted to take any photos. So apologies, we have none. Linda has just indicated she's on her way and might be a bit late. So are members aware of any other apologies? No? Okay, so just in terms of chair business, can I just point out that the committee today was to receive the departmental 6-month update on how issues within domiciliary and home care are being addressed. Department obviously aren't, as we now know, providing that update today, but the committee office has reiterated its importance with officials and that they will be in attendance at the meeting on the 22nd of May to provide the briefing and answer any questions members have. Also, just to update people, myself and the Vice Chair and the Committee Clerk met with the new Permanent Secretary there just first day of the Easter recess, I think it was, Monday. Just it was a very informal introductory meeting, so nothing of substance, but we did pass on the committee's wish that he come before us very early. That I think has been agreed. He's coming with the Minister at the end of May, 27th of May.
29th of May.
29th of May. Okay, so that's not too long to wait. Okay, draft minutes. Can I refer members to the draft minutes of the meeting held on the 10th of April 2025? Everybody content? They're a true reflection. Thank you. There are no matters arising from me unless anybody else has any. No? Okay. So we're just going to move then to first briefing. So as I said, we're having a briefing from the Association of Palliative Medicine, GB and South, Regional Palliative Medicine Group, Paediatric Palliative Care Network and NI Hospice. So the briefing obviously is on the committee inquiry, access to palliative care services. So for our information, there's a clerk memo at page 17, written submissions from the individual healthcare professionals to the committee's call for evidence, and that's at pages 27 to 63, including a submission at page 3 of the table papers. The Department Strategy for Children's Palliative and End-of-Life Care 2016 to 26 is at page 64. Also a progress report and a strategy from June 21 is at page 98, and we also have a copy of the antenatal palliative care pathway from the Regional Paediatric Palliative Care Network, and that's at page 109. So can I welcome Dr. Matthew Doré,
Yes.
hopefully I got that right, Association of Palliative Medicine, Dr. Alan McPherson, Regional Palliative Medicine Group, Dr. David Graham, Paediatric Palliative Care Network, and Dr. Claire White from NI Hospice. So these are all very welcome. Thank you and your organisations for your contribution to the inquiry to date. So I'm going to hand over to you just for some brief introductory remarks before we start with questions from members. So hopefully you have agreed an order.
We haven't agreed an order, actually.
Okay. Well, do you want to go from right to left or left to right?
We've each got introductory
Yes.
10-minute speeches. Is that
Tear away.
tear away? Shall I go first then?
Go ahead.
So, dear Chair, thank you, committee members and esteemed colleagues. I stand before you as the Association for Palliative Medicine of Great Britain and Ireland, which is the professional body of palliative medicine, but also I am a lowly local clinician. I want to outline my thanks for first having this inquiry, thank you, but also to the many previous evidence givers throughout this inquiry. I have now listened to almost all of them, and with speed, what did they demonstrate? Well, Marie Curie outlined the geographical variance in Northern Ireland, need for a 7-day service, and integration between health services. Macmillan worried about delayed referrals, 60% of them were too late, wanting mandatory palliative care training, and holistic support for patients. NI Hospice outlined workforce shortages, children's palliative care heavily under-resourced, and a call for palliative care to be embedded within our legislation. You heard from the All Ireland Institute outlining the difference of fully funded 100% palliative care funding across Ireland, but also that Northern Ireland spends £12.50 per capita on palliative care versus the £28 in England, behind both substantially. We heard from the Royal College of Nursing about the level of burnout due to the unsustainable workloads. We heard from the BMA demonstrating the fragmentation of palliative care services, the lack of standardisation and GP overload. Indeed, the GPs outlined a lack of clarity of referral pathways as systems is not truly integrated and are variable. You heard from the trusts outlining further the complete postcode lottery we have, the staff recruitment and retention issues, as they are currently underappreciated and under-resourced. And from the Department of Health, their evidence outlined the inability to introduce a strategy from 10 years ago, which was formed with data longer than 15 years ago, and that in parts it remains embarrassingly unfunded. And only now, during this inquiry, and because of this inquiry, I believe, has the department started a scoping exercise to see what services are actually currently there, because they don't know. And most importantly, you've had patients and family representatives outlining delays in symptom management, an unnavigatable system, and bureaucratic barriers. We are currently witnessing a silent crisis in our palliative care system, a crisis of neglect, inequity, and failed leadership. It is indeed ironic that palliative care of all areas is currently palliative itself. The evidence is irrefutable, consistent from many organisations, and I want to say my headline first. I plead for your hearts to hear from the most vulnerable in all of society, those who are dying, that Northern Ireland palliative care needs immediate urgent action. There is not a single metric in which we are ahead or on a par with the UK or Ireland. We are dying for help. There is also a danger looming, a social reaction to poor care, a fear reaction, that in our moment of greatest need, we will be left suffering without help. That danger is assisted dying, also known as assisted suicide. This is born out of the neglect and fear of a system which won't look after me. The top 5 reasons people have lethal medications are all social, including feeling a burden on family and friends at 46% in Oregon. Indeed, Oregon does not have what most consider a functioning palliative care system. Ask why people want this choice of lethal medications. It is because of this fear. The narrative of kill the sufferer rather than treat the suffering is a result of our leadership looking the other way over those people who are dying. It is a sad fact. It is only because of this terrifying prospect, i.e. we could deem some lives not worth living through assisted dying, that we are looking at palliative care properly now. Thank you. I want to offer you a vision, a legacy to look towards. I can see this small but very determined nation being the standard bearer for how to look after its population. Imagine the best in the world, value and worth bestowed into its people. Imagine the peace of mind that we will always look after you no matter what happens. Your worth isn't based upon what you do, but that you are you. Now, imagine the message that sends to the rest of the world. I'll be accused of exaggerating, but I really disagree. The standard of looking after the dying is the marker of the standard of worth the country places upon its people. I'll say that again. The standard of palliative care is the marker of the standard of worth the country places upon its people. I'll go further. If you fix palliative care, you will make a great leap in the work towards fixing the health service. It is the lighthouse, you see. Let's make patient-centred care the greatest of all the attributes. But there's no money, I hear cry. No, I do not accept that answer. There are priorities. There is a hierarchy of what you deem important. Palliative care is not an optional add-on. It is an essential service, and few would disagree following COVID, I would argue. There is also low-hanging fruit. You probably have already heard about them. Why on earth don't we have respect documents, the advanced care planning, power of attorney for health and welfare, which almost every country in the Western world has? They are lost in a bureaucratic tangle outlining complete and utter inefficiency, incompetence, or inability to progress through loss of purpose. Here is a quote. "A machine is perfectly designed to give the outcomes it gets." This has been said by Professor Max Watson as well. A system is perfectly designed to give the outcomes it has already got. We've got those outcomes. Our leadership is broken. The PCIP, Palliative Care in Partnership, is not fit for purpose. No blame on any individual. However, the system is not accountable, not beholden or answerable, defers responsibility, and has no ability to progress any single thing forward. Just rehashing the unachieved aims over and over again. Indeed, the APM has been blocked from joining its board. Through the Department of Health, alongside many others, the APM calls for a national clinical lead, same as in every other nation, to hold lack of progression to account, to hold the Department of Health to account to its population. This cannot be shirked. Secondly, our legislation needs updating. At present, Northern Ireland does not mandate palliative care as a statutory duty. In England and Wales, Baroness Finlay's amendment changed this. Why not here? The APM demands there be a legal duty to fund and provide palliative care for our population. I've been referred to the Reform Act of 2009 to say this is already in place. What balderdash? It doesn't once mention palliative care, and irrespective, it hasn't worked, has it, in 16 years down the line? Is it ignored legislation, poor legislation, or doesn't do what it's been claimed? Service specification, thirdly, needs accurately done. To accurately attribute commissioning, all the services should be accurately specified. There is no definition of a hospice, for example. We need to accurately define this to accurately fund it. But fund it we must. Do you see how far behind we are? Palliative care is an essential service and should be 100% funded, not the current token non-inflation less than 50%. What message is this sending that we don't fully fund palliative care? The NHS promises cradle to the grave, yet abandons people at the grave. Hospices are forced to beg for funds while other services, such as oncology services, grow by many folds over. All palliative care services in Northern Ireland, let's face it, have essentially been stagnant for the last 20 years. Why is palliative care recurrently the bottom of all priorities? With 100% funding, we need to have both specialist and generalist services available 24/7, 7 days a week, as per NICE Guidance 2006. We need single points of access and a truly integrated system. But you know all this, all the evidence. We have said it for 20 plus years. My final plea, this is not about politics, it's about people, and we are failing them. What legacy do you want to leave behind? Can I give you one which stands the test of time? Shout for those who can't. Build a country in which we care for those who now can't. Choose dignity over neglect, action over apathy. Thank you.
Thank you. Who's next?
Do you want me to go ahead? Thank you. So, yes, thank you for inviting me here to speak. So, I'm Claire White, and I've been a consultant in palliative medicine for over 16 years. I work between the Mater Hospital, where I see hospital inpatients, and the Northern Ireland Hospice, where I work within the specialist inpatient unit and in the community alongside our hospice nurse specialist team. I'm hoping to speak a little about the need for specialist palliative care, especially with respect to why, despite the push to move care into the community, we still need specialist inpatient units and some of the challenges that we face working in this area. So why do we need specialist palliative care? Generalist level palliative care, looking at the basics of controlling symptoms, providing psychological support and identifying those who are dying, should be able to be provided by all medics. In the same way, I don't need a cardiologist to manage my patient's high blood pressure or angina, unless that becomes complex or difficult to control, when I may need to call in a specialist. Generalists should be able to provide palliative care to the majority of patients who are facing the last few days, weeks or months of their lives without high levels of complexity, and many patients can live well until they die peacefully, only requiring generalist palliative care. However, in the same way there's a need for consultants and specialist nurses in other specialties such as cardiology, there's a need for specialists for palliative patients whose needs cannot be met by generalists, and that is where specialist palliative care comes in. Often working alongside hospital teams to get people symptom controlled and discharged back into the community, or alongside GPs to keep people comfortably at home. Specialist expertise is needed for those with difficult to control symptoms despite generalist care, such as severe pain, intractable vomiting, extreme shortness of breath, intense anxiety or distress, to name a few issues, alongside providing support for the patient and their loved ones facing death with these challenging symptoms. When patients experience issues that cannot be controlled by specialists in a hospital or the community, that is when a specialist inpatient unit or hospice is required, a parallel to the coronary care unit to continue the cardiology example. In a specialist palliative care unit, we aim to control these symptoms well through access to holistic care through our multidisciplinary specialist teams and the use of complex medication regimens. For many, we aim to control their symptoms and discharge them, but for some, they will end up spending their last days of life in a specialist unit. Those would be people who cannot die elsewhere due to the complexity of their condition, be that difficult to control symptoms or social circumstances that make home not possible, such as having young children living in the home with them and their choice not to die in front of their children. Palliative care is not a specialty just for older people. We have many parents dying who are leaving behind young families, and approximately half of those admitted to our inpatient unit are under 65 years old. As I'm sure you can imagine, knowing you're dying and leaving dependent children requires specialist support, both for the parent and for those that they leave behind. Over the years I've worked in specialist palliative care, I've seen many patients being admitted to the Northern Ireland Hospice inpatient unit with intractable symptoms, crying, unable to move due to pain, gasping for breath, vomiting copiously, confused, agitated, wanting to be dead because life had become so miserable it was no longer worth living. But with the right balance of medication and holistic support, I see these people transformed within days to people who are comfortable, clear in their thoughts once more, often able to get out of bed, able to have important conversations with their loved ones, and have regained their desire to live and enjoy life for as long as possible. They still have a limited time to live. We haven't changed that. But what we have given them is the opportunity to live well until they die and enjoy the time that is left. And while that is vital for them, it's also vital for their loved ones. To know that the person you loved died peacefully, with comfort and dignity, and that you had the opportunity to tell them that you loved them and say goodbye properly, helps ease the rawness of bereavement and allows those bereaved to recover sooner and to be able to continue living their lives without crippling memories of unnecessary suffering. When I talk to patients about their fears, for the majority, their biggest fear is the fear of dying badly. Distressed, suffering, in agony, gasping for breath, and for their loved ones watching them die like that. I can confidently reassure people with access to the right specialist palliative care this should never happen. We have access to medications and specialists that should ensure nowadays that no one should die like that. But they may need to be in a specialist unit to enable them to die comfortably if their needs are complex. I work in community and in hospital, as well as the specialist inpatient unit, so I'm not naive enough to think that bad deaths don't happen, because I hear about them. But it's usually due to a failure in care, with an impending death not being recognised, and access to appropriate specialist level care, and this unfortunately happens too much. But in order to be able to provide the level of care required for the most complex, which is the level of care that I think we would all want if it was us or our relative or loved one who had difficult to control symptoms, we face many challenges, one of which is funding. No cardiology service is run by charities and dependent on people running marathons, having coffee mornings and selling second-hand clothes. But that is how a lot of our funding happens. If it wasn't for historical reasons, people would be horrified to think that it takes charities to provide good symptom management and end-of-life care for the most needy patients in Northern Ireland, rather than this being a core function of the NHS. There are many other challenges which others will have spoken to. Pressure in beds due to delays of discharging patients due to lack of care packages in nursing home places. Hospices not being on Encompass, so risks of information being missed. The lack of a regional DNA CPR form and the lack of an implemented advanced care plan document such as Respect. The absence of these compromises continuity of care for patients and makes the health system inefficient by requiring duplication of work. The challenges faced by our patients are many, but we need good systems in Northern Ireland that ensures that some challenges can be reduced, such as access to medications when people need them, including out of hours, and 24/7 support to keep people living and dying well. And I'm sure many others will speak to these issues, so I will not today. So in conclusion, I really welcome this inquiry and the work you're all doing, so thank you for prioritising palliative care. We know palliative care works. We have decades of research that shows palliative care improves quality of life for patients, reduces people being admitted to hospital at the end of their lives, hence saving money, improves well-being for carers. And it works best when it's provided early as an extra layer of support. I love my job, and I want to be able to continue to provide excellent symptom control for those struggling at the end of their lives, to ensure that all die peacefully, comfortably and with dignity, which I imagine is the least we'd all want for ourselves and our loved ones. But to do this, we need properly funded palliative care services, not just in the community and hospitals, but specialist inpatient units are essential for the most complex of patients who cannot be cared for elsewhere. I know many of you have visited our specialist inpatient unit and hopefully got a feel for how essential the unit is for our most needy patients. And any of you who haven't had the opportunity to visit would be most welcome to come and see firsthand what we do and why it is essential. I'd be delighted to show you around and introduce you to some patients who can explain the need for specialist units much better than I can through their lived experience. So, thank you.
Thank you.
I go next.
Yep, go ahead.
So my name's Alan. Thank you very much for asking me to come to speak today. I am speaking on behalf of the Regional Palliative Medicine Group of Northern Ireland, the RPMG. We are made up of all the palliative medicine doctors from across the province. That's consultants, hospice medical directors, staff grades, senior trainees, working across all settings, including our hospitals, our cancer centres, our hospices and communities, and across the whole of the province. The purpose of the RPMG group, we contribute to our local regional guidance. We provide representation at the clinical engagement group within the PCIP structures. We're active nationally through the APM and the National Clinical Leads. We speak at our national conferences. We have given evidence at the Royal Commission in Westminster in January. However, above all, we want to provide leadership and a necessary senior clinical voice for our communities in Northern Ireland. It is as leaders that we welcome this opportunity to come and share our views. I have a clear mandate from the RPMD of what I have to cover today, but I have to say I've really struggled to write this and really struggled to know what to say, and I was up at 2 o'clock this morning still trying to work out what to say, so bear with me. Because there'll be no surprises here. I've watched the great and the good come and giving evidence in front of you, and I'm repeating a lot of what they've already said. We have our written submission in evidence already, and I'm repeating a lot of that here. So, to briefly summarise our position, the access to palliative care in Northern Ireland currently is not good enough. Our services are actually pretty good. Our problem is in accessing them. They are complicated to navigate. There's unnecessary regional variations. Demand outstrips capacity, and our services are chronically underfunded. We have gaps in our care provision that have never been addressed. These gaps are probably getting worse, and we do not see a plan for how these are going to be managed into the future. We know the well-publicised impending demographic changes, and we worry about how those will affect us. It is said that Northern Ireland may now be lagging 20 years behind the rest of the UK in terms of our palliative care. We have no legal right to palliative care. We don't have a policy for palliative care. Our policy, Living Matters, Dying Matters, of 2010, died in 2015. The RQIA reviewed the implementation of the strategy in 2016. They concluded that the implementation was constrained by the limited provision of statutory funding. We are the only region in the UK and Ireland that does not have a national lead. No one is accountable for our standards or for the development of palliative care in Northern Ireland. Northern Ireland has written an advanced care planning policy, but we've been unable to implement it. We've been unable to finish the implementation of our Mental Capacity Act. Therefore, in Northern Ireland, we are unable to appoint a health and welfare lasting power of attorney. And I'm not aware of any plans to address this shortcoming. We've never been able to implement a regional DNA CPR form. We've been waiting for this form, I think, from about 2005. Our Specialist Palliative Care Workforce Planning Report 2017 to 2024 was a bit controversial at the time, and I believe it's never actually been published and implemented. The Palliative Care in Partnership Programme Board and its subgroups have perhaps possibly fallen a bit short despite having really good people involved working very hard. Perhaps it's in the structure, perhaps it's in the lack of authority, perhaps it's because the programme team rely on charitable funding. I'm not sure. We haven't been able to develop 7-day working or robust out-of-hours services despite this being a recommendation from NICE for over 20 years. We have not seen fair and transparent commissioning, perhaps. Within the Department of Health, palliative and end-of-life care is fragmented and siloed across different departments. Our public health messaging perhaps falls short. Maybe that's because the Public Health Agency don't have a clinician currently responsible for palliative care. I'm not clear what our plan is to provide the necessary supportive care for cancer survivors. To my eye, our measuring and metrics seem to be virtually non-existent. Our list of shame goes on and on. However, perhaps our biggest problem, our recurring theme, might be our inability to affect change. Maybe in health and social care in Northern Ireland we can talk and write reports, but we struggle maybe to deliver. We have really good people working really hard, but just can't get stuff done. It's just not good enough. Could you bear with me if I shared just some personal reflections? Because I'm getting old enough now that I'm starting to reflect over my career and considering what the last bit of my career should look like. You know, I graduated from Queen's 25 years ago and I've done all my training largely in Northern Ireland. My first consultant job was in the Northern Trust and I'm now a consultant in a charitable hospice. And I reflect back, growing up through the horrors of the Troubles, health and social care in Northern Ireland was seen as better than the rest of the UK. We were ahead of the curve. We'd integrated health and social care together. But over these years, perhaps most noticeably through austerity in 2010, I wonder if our services really come off the rails from that. And then we've had Stormont collapsing a few times, then COVID, then Brexit, and then cost of living, and now with wars and tariffs and uncertainty. It's hard to maintain a bit of hope through all of that. We are a post-conflict society. We have significant socioeconomic problems. We have mental health issues. We have drug problems. And we have people living chaotic lives who might be at risk of chaotic deaths. While we're working in an increasingly broken system with later diagnoses, younger patients, demoralised staff, under-resourced GPs being asked to do more. I believe that we used to spend 10% of our health budget in primary care, which was inadequate. Now I believe it's reduced to 5%. And there's not enough carers available to provide the necessary social care. We see a knock-on effect of that into specialist palliative care being asked to take on more and more. It's now commonplace for me to see patients refusing to go to ED who really should be in ED. There's an increasing demand for palliative care to pick up increasing complexity in the climate of increased financial uncertainty, chronic underfunding of hospice services, and an impotence to effect change or implement improvement. Maybe in Northern Ireland we have a perfect storm of reduced capacity, increased complexity of demand, and an absence of leadership. However, perhaps our greatest existential threat to palliative medicine in Northern Ireland at the minute could be seen as assisted dying. We look on while all of our neighbours are proposing legislations to allow for assisted dying. So the RPMG has performed a survey of its members to understand our opinion and to provide a mandate to speak against. The survey has been published in the Ulster Medical Journal, and I have brought copies with me. But briefly, our results show that 100% of responding palliative medicine consultants and registrars would not be in favour of change of legislation allowing for assisted dying. 93% are concerned that assisted dying will be influenced by cost savings for patients and families. 82% were concerned assisted dying will be influenced by cost saving for health and social care. 53% would not work in an organisation that undertook assisted dying. 40% weren't sure if they'd work for that organisation. I can understand why the RPMG survey was so uniformed and conclusive. How can we justify a commissioned assisted dying service in the context of such a broken health system, which struggles to provide access to services, which cannot currently provide choice, and which charitable hospices are providing the majority of palliative care, that are experiencing chronic underfunding and funding pressures? By way of summary and conclusion, we have good people working very hard to provide their very best, but we have problems. I think firstly, to begin with, we need to address our problems to find ways to deliver change. I would suggest we need to see palliative care as an essential service for all who need it. We need a national lead. We need better structures within the Department of Health, the PHA, the Palliative Care and Partnership Programme, providing transparent, accountable and responsible leadership with authority. Then we need to think about getting the basics right, a strategy. We need to do some workforce planning. We need to think about our commissioning and developing multi-year budgets. And we need to start measuring stuff and using that data. And lastly, we need hope. We need hope that things can and will change. Thank you.
Very important. Over to yourself.
Thank you very much. Thanks for inviting me along today. I'm David Graham. I'm a paediatrician in the Southern Trust, and I'm the co-chair of the Northern Ireland Paediatric Palliative Care Network. And it's struck me, it's quite powerful to hear how passionate everybody is here today talking about this. And I'm hopefully going to give a voice to the children and the families that I've worked with for many years, and many of the teams that I've worked with, and the difficulties we see in paediatrics and palliative care. I've been working 20 years in paediatrics now, and past 10 years as a consultant, with part of my job being in palliative care. But I've been involved in the Palliative Care Network since it was formed in 2019. Prior to that, we just had a special interest group with dedicated clinicians and hospice team members who tried to develop things in Northern Ireland in relation to paediatric palliative care. So I'd like to just talk about some of the issues I see and the network sees, and things that we could possibly change in the coming years. I'll start off just about the understanding of palliative care. I know I was asked that in my written evidence, and there is a widespread misconception, particularly amongst the public and healthcare professionals as well, that palliative care sort of is synonymous with end-of-life care, but in paediatrics that's far from the truth. I'll give you the World Health definition from 2013, World Health Organization, that palliative care for children is the active total care of the child's body, mind and spirit, and also involves giving support to the family. It begins when illness is diagnosed and continues regardless of whether or not a child receives treatment directed at the disease. Health providers must evaluate and alleviate a child's physical, psychological and social distress. And effective palliative care requires a broad multidisciplinary approach that includes the family and makes use of available community resources, it can be successfully implemented even if resources are limited. It can be provided in tertiary care facilities and community health centres and even in children's homes. So the reason I just wanted to mention that was that for me, and it is well known, that paediatric palliative care often begins at the time of a diagnosis of a life-limiting or potentially life-threatening condition, and we see families from before birth right up to 18 years of age quite often. And what we aim to do when a child and family receive that diagnosis is our aims to improve the quality of life and support families emotionally, practically, helping children to live as well as for as long as possible. And it's a long-term holistic approach and not just that final stage. And that, I suppose, contrasts in a bit to what was seen historically, particularly in adult palliative care. Not that I'm an expert in that area, but that was often seen last year of life, and whereas paediatric palliative care is quite a longer duration quite often. And things may be changing in the world of adult palliative care in relation to that. The second point I wanted to come to was just the underfunding and inequity in the services for paediatrics. Children in Northern Ireland don't have equal access to palliative care. There's different groups of conditions that can lead children to have life-limiting illnesses, and I suppose one of the biggest groups we think about are children with cancer, known to oncology services, and they probably have a better level of palliative care support. I wouldn't say it's ideal, but it's a better level than other groups of children. And the other groups of children I'm thinking about and that we see week in, week out, and who are frequently admitted to hospital with multiple health problems, are children with severe neurodisability or rare genetic conditions. And they're far less well served in relation to paediatric palliative care. We need to think about how that can change in the future in some of our plans and strategies. At the moment, there's no dedicated funded paediatric palliative care teams or end-of-life teams anywhere in Northern Ireland, as recommended by the NICE quality standards from 2016. And the core team that they recommend in their documentation, in their quality standards, is to have a paediatric palliative care consultant, and that's a consultant who has specific specialist training in paediatric palliative care, a nurse with expertise in paediatric palliative care, a pharmacist with expertise in specialist paediatric palliative care, and then also thinking about experts in child and family support who have experience in end-of-life care. And that would include support for social, practical, emotional, psychological and spiritual support. So that's something I know that we're currently working on as part of the network, thinking about how we can develop that in the future, but it's something I wanted to bring your attention to. At the moment in end-of-life care, if we think about that specifically in children, most of that work is carried out by our community children nursing teams in each of the trust areas, as well as specialist nurse teams, maybe from the Children's Hospital in Belfast, who might be oncology specialist nurses or hospice nurses who can provide support to the families. It's a common theme at all of our network meetings that those teams aren't funded properly. They work on goodwill. They will often a 9-to-5 service in most of the trusts, and then when it comes to end-of-life care, out of hours, weekends, they just pull out all the stops, goodwill, not paid, and they will work above and beyond to provide that service. And that's an ongoing problem in paediatric palliative care. As well as that, there's no consistent medical cover funded for children receiving end-of-life care. And it's not a sustainable model, and families are often left very vulnerable in that situation. I mean, I've been asked on a few occasions over the past couple of years by families who want to remain at home for end-of-life care with their child, why there isn't this specialist input that they feel is vitally needed. And just going back to last year, there was a family coming up to a bank holiday weekend, and the amount of stress and anxiety that brings to a family when they feel who can I have on the end of a phone even, who can I get to come out and see my child. And it's something that is a big problem. The other area then I wanted to touch on was transition and young people from the age of 14 upwards. I feel that they're very poorly served in relation to palliative care. There's a grey area between paediatric and adult services in many areas, and families often feel in a vulnerable position again in this situation. Any child with any health condition as they transition can be a big problem, but for this group of children and young adults with a life-limiting condition and complex health issues, it poses further problems due to the need for multi-specialty input quite often, advanced care planning, increased technological needs. By that I mean like breathing support and feeding support, and a fear of how they'll fit into the adult health services. Quite often there's no clear lead or equivalent doctor in the adult world for these families who will take on the care and look at a holistic approach for the families. And that's a big problem because it's recognised by the work of Fraser, who in her Make Every Child Count paper from 2020, that the mortality risk in young adulthood increases for these children with life-limiting conditions, and that's really something we should be focusing on as a target area to improve that journey for the child in the adult world.
So Dave, just to clarify, the transition is from a children's to an adult service, not transition in terms of sex or anything, just to
yes,
make that very, it's a transition from the child services to the adult services.
Another issue is we don't have any up-to-date data on how many children in Northern Ireland are living with life-limiting conditions, and other parts of the UK have done this work. For example, in Scotland there was a CHISP study, CHISP study from, I can't remember the exact year, but that's the study we try to equate our data in Northern Ireland to. So for us to really develop and drive things forward, we need some way of getting accurate data for all these families, children, and it'll really help us to then improve how we can manage our services and develop things. There's often poor integration between our services. I'm thinking between primary care, secondary care, community teams, specialist teams, and just going back to the transition between from paediatric to adult services, there's often very little connection there for children and families moving between those services. And families often end up having to do a lot of the work of coordination themselves, taking a lot of things on that they shouldn't be taking on. So the last point I want to talk about are just what things need to change. And although there's good examples that we've been working on, and as the part of the network, we've been working on the previous strategy from 2016, and we've achieved some of the things we've set out to do in that. I think the antenatal palliative care pathway is an example, and then there's the nurse pilot, the specialist nurse pilot in Belfast. So there's some areas of sporadic development in certain areas, but we really need to regionalise and improve our whole regional approach. There's several clear and achievable things that I think we need to think about, and a funded end-of-life care team for children with access to 24/7 cover. It's something we're actively thinking about in the network, but I think we are struggling to develop that, and I think that's something, if we could get funding and progress that, it would be vital. We need to think about better training for our future specialist paediatric palliative care consultants and nurses. At the moment there isn't good defined pathways for that. Regional model of care with pooled resources and shared expertise. Improved transition pathways for young people, specifically with life-limiting conditions. And an updated palliative care strategy. Our strategy at the moment is due to be renewed in 2026, and if we could take that forward, that would be fantastic. And just going back to some points made about legislation as well, and I know in other parts of the world I've heard some talks from a colleague in Canada who talked about how once legislation for paediatric palliative care was introduced in that part of Canada, it really helped to drive forward the progress with the services they could develop in that area. And I'm sure there's other examples of that we can give. And then the final thing was just the reliable data that I mentioned before to provide planning and service development. So thank you for your time.
Okay, thank you to all four of you. I mean, that has been very, very useful. As always, with regard to the evidence that we've heard before this inquiry, it's been delivered with passion but expertise, so we really appreciate that. A lot of the stuff that you've said we have heard before, but it's always good to hear a different perspective, and sometimes it's really good just to reinforce it. So one of the things, and I'd say this to members before we start, because we will have a lot of questions. There's four of you in the panel, so if any of the members have a specific question for one of the specific panel members, just point that out. And if we have a general question, perhaps on the panel, if your colleague previously, or if your colleague answers the question, rather than having all four people answer the question, if there's something important you want to say, we have time to do that, but just so we can get through as much as possible. So one of the things that we have heard from right at the beginning is the need for a clinical lead, and it was mentioned here today. Can I just ask generally, has there been any engagement with the department to this point on that position, and if you're aware of any specific feedback in relation to it?
It's not been a new thing said, if that's what you're asking. It's been recurrently said, certainly at our through RPMG, through APM, through those kind of mechanisms, and it's been said at I would suggest at the clinical engagement group and the PCIP. That has been said. Has it been direct engagement with the Department of Health? I am not aware of anything, unless my colleagues are aware of anything formally, but this is not a new thing. This is something which has been half a decade or more mentioned.
And I mean, essentially, I'm probably asking the wrong people, but you're saying it's not a new thing, and it seems an obvious thing. I'm kind of asking why it doesn't exist currently, and if you're aware of kind of the roadblocks.
I don't know, but I look on at colleagues in Wales and England and Scotland and the Republic of Ireland, and I see their national leads, I see what they're producing. We heard from them at the Palliative Care conference this year. So I know Idris Baker in Wales is doing lots of work as their national lead at the minute. I suppose we look on with envy a little bit that nobody has taken on that role for us.
Okay. Fair enough. And then just quickly, because one or two of you has mentioned the lack of understanding with the public and in relation to palliative care. So that's something that we have continually heard. So how do you think we can change that perception, or what's required to change that perception?
So the public perception of palliative care. Is that what you're about? Yeah.
Knowledge. Perception and knowledge.
It has to be all-encompassing work on multiple levels, to be honest with you. It is that we have, as you know, we spent the last 50 years telling people we don't kill them when they come to the hospice, and that message is slowly getting in. I would say the biggest thing is that, and I'm repeating myself, is that palliative care is recurrently not prioritised at all, and therefore the resources we've got to tell things are left to charity and goodwill, and therefore there isn't a national scheme. If you even look behind you, the Committee for Health, those bubbles, which I presume are your values, one of them says prevention is better than cure. Again, it's at every single level. It's about cure, prevention and other things, and not anything to do with end of life. And the banner just behind you.
Fair enough.
And I suppose that some of the charities have done some promotional work, in Dying Matters Week and things like that, doing a bit of a publicity campaign, but probably something coordinated at a much higher level with much more impact, and right from schools up, to adults. I suppose if you influence schools, that's how you influence the next generation. But certainly, more information out there available to people to take away the fear and the stigma. I suppose it's the way cancer used to be. People in my grandmother's would never have mentioned cancer. You never said the word cancer. If somebody was dying of cancer, the word cancer is never recommended. I think dying is still, for a lot of people, is still a taboo. So we need to be able to talk more about it. I think the more that is talked about, the more that enables people to talk about their wishes for care.
I mean, one of our themes that we have obviously heard throughout the inquiry is the inequalities of service. So some places are better than others for a variety of reasons. What I hadn't heard until today, Dr. Graham, was just the difference in paediatric services. You said that children with cancer, are likely to get a better palliative care service than perhaps children with complex, life-limiting, rare genetic. Why is that? Is that because of the knowledge within the medical profession, or is there another reason for it?
I think traditionally the oncology team, and thinking specifically within the children's service in Belfast, would have provided, from a medical point of view, they have an on-call telephone service for problems out of hours. They don't do any home visits or anything like that, but they would provide advice and support over the phone. And then they also have Macmillan nurses and oncology specialist nurses as part of their team that can provide a bit of outreach support. There's no real equivalent for other groups of children in other life-limiting condition and categories. And I think why that's been is maybe just been oncology has perhaps been better funded up until now, perhaps.
Okay, fair enough.
I was going to say, I think that's how adult palliative care services, they grew up through oncology. It started as palliative care used to be just for patients with cancer, and I suppose it has developed the way paediatrics, I suppose, is probably just lagging a bit behind, that, because but it's still in adult palliative care, oncology patients would probably get better access to palliative care. Okay,
and then just I can't remember who mentioned, that there is low-lying fruit there. I mean, obviously we're doing an inquiry. We will be producing a report. We'll be making recommendations at this stage. I don't know how many recommendations there are. Some will require funding. Some perhaps won't require funding. So maybe if we move from left to right, could I ask, just in terms of 3 key areas that you think that could be addressed as a matter of urgency that would make a big difference?
I think proper funding for hospices and for the charitable sector. I think that's huge. That your services are sustainable. That you're not going to be having to close your doors or close your beds in 6 months or a year's time if your charitable funding dries up, or so I suppose funding both to sustain your services but also to grow your services. There's so much potential, like all the things we're talking about and that need done. There are brilliant people working palliative care. The people are there who can do it and have the will and the desire to do it, but they just need the resource behind them to do it. So I suppose funding. I think there's the low-hanging fruit, the regional, advanced care planning documents such as RESPECT, the DNA CPR. All the work's being done on that. Funding's being poured into that. But yet we still have, if we have somebody in hospice or hospital setting who's not for resuscitation, the GP then still needs to do paperwork and potentially have a conversation. It's so inefficient, and it's for both healthcare professionals but also for patients, and their families. Third one, they have more time to think than I do. Come back to me in a third.
Okay, go on, Dr. Boyd. If there's anything different,
I'm sure these guys will.
So our legislation, I understand this committee could potentially legislate. I know time is an issue. I would strongly encourage you to really consider there needs to be legislation in place to act as a wall for commissioners to get things out and done. And there's been, I guess, to give you a tiny bit of history, in Laura Finley's amendment, that the commissioners, the ICBs in England and Wales, then gave the money to general palliative care in GPs without so much doing specialist palliative care. NHS England released a whole document outlining that there has to be a bit of each. So you can make this legislation better, learning from England and Wales, that you could take and so equally go to specialists as well as generalists. one, legislation. Two is the structure. I think there is a fundamental problem with the current structure of leadership. And that, as I said in my opening remarks, we've got a machine which we know it's the perfect machine designed for the outcomes we've got. And we've got these outcomes. We know this machine works as it does. So we need to adjust the machine to get different outcomes. And the current machine has all these liturgy of things which have not been achieved. How do we achieve those? We need to change that machine a little bit. National Clinical Lead is part of that change of process to try and get, because I think what you're getting impression is we've been telling these things and nothing's been happening. And that is exactly how we feel. We don't understand, it's not transparent how decisions are made, it's not clear who makes those decisions, and everything is obfuscated and we can't go through things. The third thing is, in link to funding, to link to Claire's, is that you need to have service specification, accurate service specification of every palliative care service here in Northern Ireland, because you need to know what the commissioners are commissioning for. And I think that is, the commissioners come back and say, well, I don't know what I'm commissioning. Well, we need to give them really clear what are the different services across all of the region of Northern Ireland, and then they say, well, actually, there's a legal right to a legal right to palliative care. Definitely not assisted dying. No, oh my goodness, definitely not that. And we need to provide it because it's a duty. These are the services. The structure allows, instigates changes, and they hear and we commission them appropriately.
Thank you. Dr. McPherson.
Thank you. I'm a wee bit conflicted because I think there's so much, and by trying to do so much, we maybe will write more policies and more procedures, and maybe they'll sit on shelves and we'll never quite get stuff done. So I'm maybe not thinking about legislation per se right now, because that will take time, that might take years. Writing a strategy might take years, and we've written a strategy and we never really got it implemented because there was not funding to do that. So I think maybe I would want to focus on the basics of perhaps running a business, getting a workforce plan, getting good metrics, getting funding, understanding our inputs and our outputs, understanding our sustainability, understanding where our strategic vision will be taking us to, but maybe not spending years writing plans. Sorry.
Thank you. Finally, Dr. Graham, if you have anything to add.
Yeah, thanks. So I think workforce for me would be very important. I think from a medical, nursing, and allied health professional holistic team around a child and the family. At the moment, as I said, we don't even have a tertiary level specialist paediatric palliative care consultant in place. There was one for a while, and that has subsequently vacant now. So we need a sustainable team with a specialist interest or specialist knowledge in the hub, and then in each of the spokes in each of the trusts. For the workforce, we need sub-teams who have some degree of additional training in palliative care, properly funded, and develop teams that all work and talk to each other in an appropriate way. So I think, for example, part of my job, a tenth of my job is palliative care, and I could spend easily full time doing palliative care, and that's the same for each of the leads in each of the trusts from a medical point of view. So I think that really needs developed from a workforce point of view. We have ideas on how to do it. It's just, I think, the funding again. So second thing is, I would say, is the data, because the data is, we go to whoever and say we need to do this. So what numbers have you got? What are you going to tell us about the number of children in Northern Ireland who have that issue? We then struggle. We try our best to piece things together, but we really need to get a good piece, and it can be done. I know it's been done in other areas in the UK, and it provides such valuable information then to develop services further. And then the last thing I would say is the redo of the strategy again for 2026. I think it would be useful to do that again. Yeah.
Okay, thank you. And we really want to give people at the end of this hope. Diane?
Yes, thank you, Chair, and thank you for your presentations. I think the one thing, Chair, to go back to what you said that does give us hope in the middle of all of frustrations is actually that we have clinicians who are really passionate about what they do. So I've asked this question to everybody, and I am going to persist with it, because I do think that the legal entitlement will drive change in terms of palliative care, and currently we do not have a legal entitlement, and I really want to see us being able to drive the commissioning of services because the department is held to account legally for not having those services. And does anybody want to come back on to me? I mean, this is a view of mine. This is not new to anybody here in this room. I've said this over and over again, but I do think it is really important. Anybody have a view on that? You Matt, expressed a view on it.
Yeah, I mean, I think if these things are fed from top down, if there is a legal requirement, a duty to provide palliative care services, then that will feed through absolutely everything, and that you create a onus, a society in which palliative care is valued. At the moment, we are not truly integrated into the health service. I mean, we're just shy of 50% NHS, the NI Hospice funded charitably, and less so with the Children's Hospice. I mean, this is a situation in which we need to move the entirety of the health service into to appreciate, well, not appreciate, to have an essential palliative care service. And if I was to go right to the top, that is legislative, and that is why I would just say, again, learning the lessons for England and Wales, that we can do that legislation better, in the sense it would, for the generalist, as Claire was talking about, for the GPs, but also specialists, so that those difficult deaths are managed appropriately as well. You need both together. You can't do one without the other. You can't expect GPs to do cardiology. You have to do both.
Can I ask David, because you're probably I think, I might be wrong in this, but I think the first clinician who specialises in children's palliative care that has come before the committee, and what you said was extremely interesting. So, knowledge is power for parents and families going through this. So oftentimes, I've experienced it myself, but constituents will tell me, a child has a disability, you expect everybody to come out of the woodwork to help you to manage that disability. In effect, the reality is that you have to fight very hard. You have to fight your way through the system and try and gain that knowledge for yourself. So what is that like for a family that discovers their child may have blood cancer or any other kind of life-limiting condition?
I think it's at a conference a couple of years ago. It was actually the conference in Belfast, the Paediatric Palliative Care Conference. There was some work done in the Republic which highlighted the family's journey through the news of a child with a life-limiting condition. And the first stage is sort of adjusting to the news, and it's often, as you know, it can be quite a dramatic, very difficult situation to be in. And then the family will then move on to adjust to their new normal lifestyle, which is far from normal quite often. And it's moving into that phase that families often feel they do need to fight for things, and it's a common theme that they will talk about. We have to fight for everything, you know. we go into hospital, we'll have to make sure everything's done this way, and the way they know how to care for their child their best. Or if they need a specific service, they will feel they have to battle or fight. It's language that's often used in that situation. So it's something that if we try and support the family better through that process and journey for them, it can, and it's something we do try to do in paediatrics, particularly spend more time with the family and listen to them and think about the holistic approach to their needs. And palliative care does fit into that, as I've said, with the holistic approach to care and looking after that child and family.
Is there a specific, is it left to a charity? Is there a specific route that parents can take, that if somebody comes and we can offer them advice, or is that something we need to develop?
I think yes, there are services out there, and within trusts there are community children nursing teams, there are allied health professionals who will visit with families, social work teams, and it does vary from trust to trust. Another very useful team members psychological support quite often, and again in different areas that's patchy. Some trusts might have psychological support for families, others don't.
David, you've just segued beautifully into my next question, because I have had this issue as a constituency query where a child is being treated in both the Southern Trust and regionally in Belfast, but psychological services have been difficult because they're only commissioned in Belfast but not in the Southern Trust. So I mean, I think we should all have access to some sort of equity in terms of what health gives us. And is that a recurring problem? Is that something that you see? Or maybe I was seeing something that was a one-off.
No, it is. It's something that in some trusts psychology services are maybe funded for certain health conditions.
Yes.
Other trusts it's more widespread cover. The other thing I was going to mention just about support for families is the hospice often provide very good, for children with life-limiting conditions. They will provide excellent support for families, siblings, and they will provide bereavement support, grief support, and all of that is, it's very useful for the families, and respite care as well.
So can I just ask two more questions?
Well,
Alan, it would be really interesting to see the results of the survey. I haven't seen them, so that's my fault, not yours, but be really interesting if you... Oh, you've left, you have some to leave, that's brilliant. Because I do think it is important. I think it was Wes Streeting that said that, it was really difficult to support for him the assisted suicide bill when actually he didn't provide, as the health minister, adequate palliative care. It was really, and so it's really interesting to hear what our clinicians say about it as well. I think that's massively, massively important. And Claire, I know we met at the hospice, and it was a really lovely morning. But you did talk about the community service that you offer, as well as the specialist service. And at the hospice that morning, we saw a very clear demonstration of how that specialist service was very, very vital to particular patients. How much of your time do you spend sort of specialists, generalists, or in the community, and can you offer some of those specialist services in the community with the right support and nursing support?
Absolutely. So, so we have a specialist service in the community. So, because some people don't need to be in a specialist unit. There's lots of people can be managed very well at home. So we have a team. Certainly at Northern Ireland Hospice, we have a team of specialist nurses who would be Band 6 and Band 7 nurses who would go out to visit patients at home, who would work alongside the GP, who would give advice and support on medication regimens, who would provide psychological support to the patients, to their families, and to kind of help guide them through the process, and support them for that. So they would be specialists, and then as consultants we would also go out and do like domiciliary visits for the most complex of those patients. So a lot will be looked after by the nursing team alongside their GPs, but for those that need it, we would have a consultant would go out or a specialty doctor who would go out and see that patient for that added level of specialist support to advise on medications at home, for people who either don't need to come into the unit, who aren't quite at that level, or for whatever reason don't want to. Some people are terrified to come into a unit because they have this fear that you go in and you die, or they just really want to be at home for whatever reason.
But you can provide some of those specialisms within the community.
Absolutely, yeah. And we would have specialist physios and things, specialised AHPs who, in some areas, again, it's to do with funding, but in some areas people can get specialist AHP input.
So how widespread is that across Northern Ireland? So can everybody have that, or
a specialist nurse? Or
is that the luck of the draw, the postcode lottery where you live? How does that work? Because I think a lot of health, and it frustrates us all in this committee, is that a lot of times in terms of health and what you're offered and what you receive and the care you receive, nothing to do with the nurses or the clinicians or anything, but just the way services are commissioned, is where you live and which trust you live in.
So there are services in every trust, but they're different providers. Northern Ireland Hospice provides, I think, across 3 trusts. Foyle Hospice provides the Western, and Macmillan provides the Southern. Isn't that right? Yeah. So they're differently provided services, but there would be specialist nurses in each area. Again, those specialist nurses, those nurses are not out every day. They wouldn't have capacity to be out every day. Now, for the most acutely symptomatic people, they might get a run of a nurse out every day or every other day to kind of advise and support. But they wouldn't. I suppose it's always a capacity issue. How many people, if they would have 30 on a caseload, that's all those people need seen at some point. So, but yeah, people have access. But again, those are people who have specialist needs get access to a specialist. So if you have a life-limiting illness but you have no complex needs, so your symptoms are well controlled by your GP, you don't have extreme levels of distress, that actually you may well be able to be managed by generalists and not need that. But if they're more complicated than that, that's when they would refer into our specialist teams. Similar to in hospital, that we have a liaison service in hospital of a specialist team that would go and work alongside the hospital consultants to give advice and support, either specialist nurses or specialist consultants. But does that answer your question?
No, that's because I do think it is important that we understand that what happens in the community, so there's a degree of specialism in that as well.
Very much so.
And it's and that's important for those folk who want to remain at home, and that we can respect that choice.
Yeah. And they would very much, our specialist teams would keep people out of hospital, and we usually wouldn't admit somebody to our unit who was not already seen by a specialist, either in hospital or in community. They wouldn't get a bed in our inpatient unit because I suppose in the inpatient unit it's for the most complex, it can't be managed by a specialist in other areas. So there's specialist palliative care professionals both in the community and in hospitals as well.
Dan, to say it a slightly different way, I would say if you've got a palliative care nurse, that is actually a specialist service. When we're saying generalist, it's actually the GPs and the district nurses looking after those in nursing homes and things. And there's different providers, and there's different levels of specialism, but generally speaking, they're a specialist nurse. And same with the liaison teams in the hospitals. If you're dying, the GI ward, they will look after you, but if you have specialist needs, then they call the liaison palliative care team. It may be surprising, but it's actually only about 15 to 20% of those dying who need a specialist palliative care service. 1 in 5, that's national, UK-wide, I don't know Northern Ireland specific. And that's normal. So for example, how many people with hypertension go to the cardiologist to use Claire's, and it's probably about a similar equivalence. The hospices, and this is why I'm very keen for a service specification, certainly NI Hospice and others are specialist units where they need inpatient stay to manage their symptoms, but yet there are other people in community, I want to stay at home, which we can manage with the specialist palliative care nurses at home. with maybe a syringe driver or whatever it is. So there is specialist services throughout Northern Ireland. My argument and Claire's argument is they're very, very much under-resourced, along with the general practitioners and the district nurses as well.
I say thank you.
Thank you. Thanks very much. Linda?
Thank you very much, and thank you to all of you, and I apologise at the outset that I was slightly late. I was at another meeting. I suppose on the back of what Diane has said, I mean, I have been very focused, certainly up to date, unfortunately, because we've been through the process around adults, palliative care. I think that the Chair's point around the understanding of what palliative care means and the difference between palliative care and end of life is really, really important. And I think, to be honest with you, the question was asked and you sort of answered it, Dr. Graham, but I suppose I want to narrow it right down and not to put words in your mouth. You were asked the question around the difference between the services for children who perhaps have a diagnosis of cancer and other children with palliative care needs or end-of-life care needs. Is bottom line resourcing. Resourcing has been put into children with cancer and has not been put into those other conditions.
I think so. Part of it, as Claire said, is historically palliative care and oncology went together. So there was maybe more need for it then. But I think as time has went on, we're seeing more children and young adults surviving with more complex health conditions and more children, young adults with life-limiting conditions. And we know from data from the Fraser work that I mentioned before in the UK, the numbers are increasing as time goes on in Northern Ireland, and that's been extrapolated from the Scottish data as well. But the number of children with those other conditions, then we're seeing more and more of them coming into hospital, very, very sick, intensive care, and as time goes on, then we're seeing older children, more of those children with complex neurodisability, genetic conditions, rare conditions, who need that extra level of support around them coming up to end of life. And the services are very, very different between those two groups of children. If I could paint you a picture of what it might look like, but they wouldn't have the same level of input probably from specialist nurses. They might have some level of hospice support and hospice nurse support and access to that, but they will quite often struggle to manage them maybe as easily in the community, and they're more likely to end up in hospital, I would say, coming up to end of life.
So I'm going to be fairly blunt in what I'm going to say. I have been dealing with a number of families in recent times with children with varying different conditions, but specifically this week, children with DMD, Duchenne muscular dystrophy, but in general, right across the board, children with those less common conditions, not uncommon, but less common. The services are, I'm going to say, non-existent. There is nothing there for those families. Paediatricians are picking it up. They are the people who those families, and that's if you're lucky enough to have an assigned paediatrician. But in terms of specialist consultants, it's not there. And I'm just wondering why, are even specialist nurses, and I don't mean somebody who's called a nurse for your condition. I mean a specialist nurse who's properly trained, who has had the training specific to that condition and understands it fully and knows then what to do and where to signpost families and how to support families and the children themselves. And for me, I mean, it then carries on through where we're having the lack of PEG services and PEG surgeries. We know the challenges for families around that. Lack of counselling, just again, and for children with some of these conditions, no counselling for the child themselves, never mind that wider family. So for me, that is really, really concerning. I don't think that there is any resource in that. I'm just wondering, could we do better at working? I'm not saying you could have a specialist consultant for every condition. I understand that's not always going to be possible, because how are you a specialist if you aren't seeing enough people with a particular condition? But why is there not more work ongoing with other areas? So where there is a specialist in the south or Scotland or Wales or England or actually anywhere in the world, where there's more work happening, you know, whether that's conference calling, I have a child with this condition, here's what's happening now. I mean, that happens in dental. If I went to my dentist and I had a really rare, challenging condition, my dentist would contact their colleagues in England and say, take a look at this, will you, and see what's happening.
So what you've touched on is incredibly important. We've got a really heavily siloed system. We've got 5 trusts and different charities. We've got goodness knows how many services. They're scoping them at the moment because they don't even know really the whole picture. And what we really need is, as I keep alluding to, a change in the structure so there's a better regional approach. The problem with having lots of microcosm silos is you cannot do those big picture things because there is not enough there. There's, you know, it's even super specialised. So you need a regional approach, all of Northern Ireland approach to this, rather than having loads of different separate silos. And that would, I think that's actually so sensible and actually is probably relatively cheap to do if you've got the structures in place. But rather than have it all sitting, Southern Trust have to provide all these super specialist services as well as the Northern Trust, as well as, you know, it has to be all a regional look at it and a direction rather than this super specialised.
What you, sorry, just to touch on what you said about the child with Duchenne or family with Duchenne muscular dystrophy. What you're probably describing is the difficulties going through the transition process more so as they get a bit older? Or
no, it's from the very point that there were a number of families met with the Minister this week, so he's well aware. It's from the very point of diagnosis and how that information is given to families and what they are given in terms of information with that diagnosis. And I think all of them actually described the process they went through as traumatic. Now, I don't mean just traumatic because of the diagnosis, because that in itself is traumatic, but some of these families may have been traumatised but wasn't entirely unexpected. This is genetic. They have other family members who unfortunately have had the same diagnosis. In some ways that can make it harder because you know exactly what to expect, which isn't always a good thing. But all of them actually said how it was managed. Everything about it has been traumatic and the service has been really seriously lacking. And it is about that really specialist and working, then having the proper training and understanding. So I think, and I've used that I suppose as an example because it was this week, but that I'm finding that with a lot of children's health problems. And just to be clear, they're saying their paediatricians are the people they're falling back to, and have been really good. You know, paediatric services have been really good. But yes, you're right. What happens then whenever they come out, you know, they move on? The families who are praising the paediatric services are still there. But then when the transition, they're going to lose that, and then they're going to realise how it is for the families who didn't even have an assigned paediatrician for a long period of time. So I suppose it's just, and I think Dr. McPherson, you've kind of probably made the same point that Dr. Doris just made around that it's the system. So is that the one? I think we're going to have a lot of recommendations out of this inquiry, but is that the one thing, if you were to say something needs to change and it needs to change today, is that the one thing that we need to change, the actual system of how we deliver palliative care right across the board? And I think the regional point is an important one.
I've lived my whole life in Northern Ireland. I do not understand the system. When I'm trying to get Beldoc at night, I struggle. When my father died in January, I struggled. I have lived and worked in Northern Ireland and I struggle. Changing the system I think is really, really important. I was very junior when there was the review of public administration, review of public something. They changed all. What was that for the better? I was around when they changed the number of trusts. Was that for the better? Did that delay? Did that push things into the long grass for years? I'm nervous about wholesale change. I'm nervous about will we be writing reports for years and not addressing the current need. However, something's got to change.
Thank you to all of you for your presentations, and thank you, Chair.
Thanks, Linda. Danny?
Thank you, Chair, and thank you for all your presentations. I absolutely get the passion that other people have referred to, and I get extreme frustration, and particularly for years and years, we've said 20 years in a career and nothing has changed. That must be incredibly frustrating to see. I would declare an interest just as a nurse who's been involved in delivering palliative care. I worked on wards where palliative care specialist nurses and consultants would have come when needed, and the difference they made to people's lives was phenomenal. As you said, Dr. White, people coming in extreme pain, vomiting, anxiety, really, really distressing symptoms, and then within hours sometimes that these people are, settled, comfortable and pain-free. It's amazing to see, and absolutely provides hope for them and the families. That this is really, really important that we get it right, and that we improve it. I did have a few questions. There was a couple of things have already been sort of covered by other people there. We have heard a lot the same things again and again, as Chair has referred to, but that means they're the same issues, and the same issues are important to everybody. So we are hearing the same things again and again and again, which means those are the things that we need to focus on, and certainly hopefully they will form the basis of our recommendations in the report. One of the first ones that jumped out, and we've heard this before, I think you had referred to it, Dr. White, about regional DNAR forms. Now, my understanding is that around the Trust there is a DNAR form within secondary care, within hospitals and ambulance service, but that stops when you get into the community. And I can't quite understand why. Because all the other documentation, if somebody's medicines are changed in a hospital environment, that continues. If somebody's care needs are changed, that continues. Why does a DNAR stop? And then why do you have to put families and patients through distressing conversations and have to go through that whole process again when it has already been decided? Can you shed any light on that?
It's crazy. It's for years. These are really, as some call low-lying fruit. That why has it not been implemented? Who knows? But that is the way it is at the minute. If I have somebody in hospital, because if I see someone in the Mater or in the hospice or at home who's DNA CPR, the onus is on that still should be rediscussed when they're readmitted. And if I have somebody who's been in hospital, we've had those detailed conversations with them, with their family, discharge them home. You're having to say GP, they were DNA CPR. Could you redo that? Could you redo the paperwork? So, some GPs just go, yeah, no worries, and just sign it. But actually, the onus is then to say they've discussed it, in the conversation they've had. So therefore, not going, I know you've already had this conversation. But just, so again, and then the patients and families are going, why are you bringing this all up again? So yeah, it's crazy. It's just a duplication work. It's more work. It's making the whole system more inefficient, and you'd think it should be easily fixed, because I've never heard of anybody who doesn't want it. There's things, I think, for probably for all clinicians, our frustrations are things that come out, all these great plans, great strategies, whatever it is, it's all brilliant. We need advanced care plan, we need regional DNA CPR, that any clinician can tell you. But then 10 years later, or 15 years later, you're still going, this still is not there, and people have talked about it for hours and hours and hours in meetings. And I think that's, I suppose, a little bit of my worry, that we make sure that doesn't happen out of this, that this is something that comes with action, that changes, I suppose, the heart, the patient-facing care, that patients get better care out of the outcome of this.
Oh, absolutely, and I can see how that would help, and it seems such a crazy idea, particularly in the community, that that isn't in place. And
it's very basic. It's something very basic. It's not. It shouldn't be complex. I don't know if you guys have any other thoughts on that.
I would say I was in Scotland 2009 when it was implemented across Scotland nationwide. Just to give you how long behind we are. It's moved on so much. To add on to what Claire's saying, because Claire's saying exactly right. We have screamed this for decades, and it hasn't been done. And now it's moved on to respect documents, which are better than DNA CPR because they outline, they've got a chart where you can outline whether they want to stay at home or not, as well, along with the DNA CPR. The entirety of the UK and Ireland and most of Europe have moved far. We are, when we say we're behind by 20 years, we are not joking. This is miles behind where we should be. And it is so frustrating because we have screamed this consistently for decades and it does not change.
And just I would just say within the last month I've heard of someone who was known, to palliative care services, they were agreed with the patient, they weren't for resuscitation, the patient was at home when they passed away. The son, I think, panicked, called an ambulance, I don't know what to do, and they did an attempted resuscitation, which is awful for, well, obviously it didn't work, but even for the family, but even for the waste of resource of that, that resource could be better used, and it was totally unnecessary. But because there is not that communication between services, that do the ambulance service know that this person's not for resuscitation? You're really relying on the family at home to advocate, to be saying no, they're not for resuscitation, and a family in that situation can panic, or maybe they're not there and somebody else is in the house and it all goes wrong.
So, sorry to interrupt you, we've been given documentation or correspondence from the department today just on the issue of respect, so I think it might be worthwhile just reading it out. Part of what they've said, so this is from the department and we've only received it today, so establishing momentum and with implementation of the policy, including the implementation of respect, has been extremely challenging within the context of other priority projects and current financial and resourcing pressures across the department and public health, although this remains an important objective for the department. A task and finish group co-chaired by the department PHA was established in January 2024 to take forward the planning for the implementation of the advanced care planning policy here, including respect. The group concluded its work in April 2024 and the department PHA are currently considering next steps. An update will be provided, so it's been sat on for over a year.
So again, priority, that word endlessly comes up. We are low priority.
Right, down the front row, but I thought that was important.
And I was going to say, if that was in, that would keep people where they want to be, it would keep people out of hospital, out of ED departments. If these conversations were had, it actually, palliative care, I genuinely think, saves the NHS money when it's done properly. It keeps people out of already overstretched ED departments, out of hospital beds, because it helps people to live and die where they want to be, which is for the majority of people is home.
And yet we're sitting on things for a year. That's
many more.
If you look at that in more detail, the respect document's been going on much further than that.
I understand
it's been going on for years.
Two other questions. Dr. McPherson, just with you'd referenced the impact of a lack of care packages and struggles in domiciliary care. What impact is this having on patients' ability to die in their own homes?
So I could give anecdotes of difficulties with discharging my patients. So I believe, I'm told, it's not that we don't have the money for the care packages, it's we don't have the bodies to fulfil the care packages. So that there is a delay then in waiting for the packages of care to come around. Please God, the patient remains well enough that they're still able to get home. On occasions, we miss the window, we miss the boat of being able to get people home to their preferred place of death. That's not a new problem, but I think it feels like it's a worsening problem, that we struggle more to get people home. I would also feel that probably we're struggling more to get people into nursing homes now than we would have before. Struggling to find available beds, struggling to find beds that don't have huge top-up costs associated with them. Those would be my anecdotes.
So it's basically preventing people from being able to die in the place that they choose to die in, effectively, and their wishes then aren't being carried through.
I add an anecdote. I had a patient in hospital quite recently who was dying slowly, probably had a few weeks left to live, and we said, oh, he'll need a nursing home place, and he wasn't well enough to go back home. And both the social worker and the ward manager said, well, he will die with us then, because there's not a chance of getting a nursing home bed within the next 5 weeks. And I was like, really? And said, yeah, not a chance, even from hospital. So again, you've got a hospital bed for this, for weeks, because we can't get a nursing home placement. It's just a whole backlog in the system. Then you've people lying in trolleys and ED. And we have the same issue in hospice as well.
And an ambulance is outside, and then at home's waiting for ambulances. It drags the whole way back. Thank you. And just my last question, just again and again, we've heard about the regional approach, the importance of having a regional approach and the regional variations. How would this improve access? And are there benefits around economy of scale? How do you see this improving access?
I think to simplify our systems, to have a regional approach, a one-team approach, to have greater understanding of how to navigate through one system, I think would be a really good start. There probably would be economies and scales within that, but actually just to try and make it easier. As I say, I mean, I struggle to navigate my way through the systems for my patients. I struggle to understand how to discharge a patient to different trusts, having been a consultant for 12 years. So to regionalise, we're small enough that we really should be regionalised. Maybe we have individual trust implementing and doing the operational work, but it needs to be driven centrally, strategically. It needs to have a central vision.
Thank you.
That is rather depressing to hear that a senior consultant has that struggle about navigating the health system. I mean, that really is a pretty depressing thing to hear, to be honest with you. Anyway, Nuala.
Thank you very much for all of your presentations and answering a lot of questions. I know some of what I've going to ask has been answered, but there's a few that hasn't. But just to say from the outset that, we're hearing your frustration and your anger at the slowness of change in policy or legislation. And, hopefully with this inquiry, and when we bring it to the floor of the Assembly and the Minister has to respond, it is an opportunity to actually highlight and shine a light again publicly on these issues. So thank you for coming again, even if you might feel that you're saying the same thing again. You've been talking about it for years. It is important for us as MLAs. I have just two questions, to be honest, that haven't been asked. And I wanted to ask David around the paediatric transition. We have heard in different fields of medicine, about the age 14 and moving to adult services and the difficulties behind it. But why is it aged 14 and in particular in palliative care? Why isn't there a higher age limit for the transition? Because this is something that is so complex and sensitive, palliative care and or end of life care. That has there been any requests or policy change elsewhere that is 14 normal in health systems? It just seems that it's a very sensitive time that families have to then transition into adult services and lose all of the holistic support that you were talking about.
Yeah, so the transition process from moving from paediatric to adult services is recommended by NICE to start around that age. NICE recommendation starts 13 to 14 years. And what that might look like, there's lots and lots of different guidance out there, different documents on how it should be done and the meetings and how they should take place with families and all the different people looking after the child. But it's over a period of years, ideally it should take place. And then by the time the child has reached 16, this is part of the problem, it's different ages for different services. For when they move from medical services into adult services, from social care packages and the adult social care packages. There's lots of different ages and different things to try and get your head around for in the families as well. It can be very challenging. So what can happen if it's not done well is, and I've seen this happen, is for example, a child who was at home on a ventilator with a tracheostomy in to help them breathe, feeding support. They had full care package at home with the nursing staff, and when they moved to adult services, some of that transition had taken place from a nursing point of view, but one particular patient I can think of, there hadn't been any real medical transition, and that patient ended up coming into hospital unwell and finding out that because they were over 16 they couldn't go to a paediatric bed, they had to go into an adult ward, which caused a significant level of distress. And then as well as that, the approach that was taken to the family and the young person in relation to intensive care, and there hadn't been any advanced care planning discussions, it opened up a whole when it's not done well, it can be so traumatic for families. I know of another family on their 18th birthday, they got a letter from the hospice, the children's hospice, saying, sorry, you're no longer able to take avail of our hospice support because you're now in the world of adults. So there is difference between the support provided in children's hospice and what can be provided in the adult hospice as well, in relation to respite and care packages and things like that. So I may be going on a wee bit off topic, but I think the transition process ideally should start at 13 to 14 and then move through as a gradual process. And in my mind, what I see, having read different transition document recommendations, is having some sort of transition team in place to help coordinate that, not just the medical and the nursing side of things, but also the social, the educational, all the other psychological, spiritual support, thinking about everything, particularly for children with the most significant level of complexity, who are the most fragile, I would say, of all children and young people.
And I imagine it would probably also differ between trusts too, with regards to how smooth.
Yeah, I think transition isn't done well at the moment. So I think it's uniformly bad across all the trusts at the moment, and there's a lot of talk about it and trying to move things on, and in different trusts are maybe further ahead than others. I can think of specific examples, but I think there are problems, and the same problems that each trust will tell you when we talk about it, that from a medical point of view, there's just no equivalent paediatrician in the adult world. Sometimes we think of GPs, but GPs are often maybe haven't had contact with this child with complex needs, because the paediatrician and all the specialists in the children's hospital have been managing their care, and then when they go into the adult world, it scares the life out of some GPs to try and be responsible in managing everything. So having some equivalent in the adult world, it can be. We haven't quite figured that out yet, but if there was someone or some sort of pathway that we could have for that, it would be good. Now, I know in other parts of the world, for example, in the Republic and in the area in Canada I referred to earlier, they have you could almost say it's like cradle to grave service, where there will be palliative care. I'm thinking specifically for palliative care and children and young people with the highest level of needs. They will have adult trained doctors caring and looking after paediatric patients. They will have access into specialist paediatric palliative care consultants who will provide that extra layer of specialist support from a paediatric point of view. But that's something that I've seen working in other areas, but if for that change to happen in Northern Ireland, I would say it would be a massive change from what currently happens, and it would need a lot of thinking around it. But having something
that was helpful. I think it's something, you know, probably as a committee in this inquiry that we definitely should, well, probably focus on in terms of our report, and maybe explore further with the trusts as well. Certainly has given me a lot more questions around the transitional arrangements and processes. My other question was actually answered, so I don't have a second question. But look, thank you very much. That was helpful.
Thanks, Noah. Alan Robinson.
Okay, Chair?
Yep, can hear you.
Yep. Thanks, Chair. Conscious that we have went over time, so we'll be very, very quick. I think it was Dr. Alan McPherson who used the term, it is like a list of shame. I suppose that is quite reflective of many of the sessions that we've had as part of this palliative care inquiry. I suppose it could be said it is similar to many sessions that we have in the Health Committee, where many of those who present to us within the health sector, it can be like a list of shame as well. Sadly, a lot of the theme today was about better funding and how better funding could help. I am conscious, though, how Dr. Michael Dorey had made reference to it is also about priorities. We all know that there is universal acceptance now across most of the political parties, if not all, including the Health Minister, that we aren't funded to need. And I suppose I've been vocal in the past in the Health Committee that I have a personal fear that we will see much of the same, even in the back of all the work and all the good presentations that we've had from many of the experts before us. And that is a fear of mine, and I hope that it is a fear that is respected. And I suppose on the back of all that, I and all of us crave good news, and we crave any glimmers of hope. And people talk today of low-hanging fruit. And I see within one of the consultation responses from one of the palliative consultants, where they talked about, and again, forgive me if my stupidity is being exposed here, Chair, but that palliative medicine consultant made reference to a regional last days individualised care plan as something that would cost little money. And as you know, we all crave that glimmer of hope. Is that just a different term than the DNCPR, or is the consultant framing that in a way of a palliative care strategy? Just could that be explained to me?
Yeah, it's different to the DNA CPR and respect. It's a form which sort of highlights when we think someone is approaching end of life, is dying, a holistic approach to their care. So it's trying to get all professionals on the same page and also bring them together to try and provide the care for that patient holistically, so psychologically, socially, spiritually, and physically. So it's a document which has been hanging around for a long time. You may have heard of NACEL, National Audit Clinical End of Life Excellence Audit. That was born out of a thing called the Liverpool Care Pathway, which was used very inappropriately, if you remember, many years ago. That was a document which people were put on, and it was a pathway, it was a one-way, so they didn't get their proper care in instances. And out of that, there was a big inquiry, and out of that came the NACEL audit. And the NACEL audit was designed to audit a document, such as a individualised end-of-life care plan, which every patient who we thought was dying should get. We are doing the NACEL audit, ironically, but not against the document, because again, it has stalled at various levels, and it's not transparent where it's stalled. And this is I know we go over time. I worry, and this is maybe speculating one step too far, but in good, inverted commas, good management doesn't progress it further. And I wonder that being a, inverted commas, good manager keeps people, not just the whole system, keeps people quiet, and these things don't get higher up to actually instigate change throughout the many levels which these things have to go through. And it's just a perspective to look at in terms of through the Department of Health. These things have been raised, and this again has been raised over a decade at least, in terms of it would be a document, a regional document, especially pertinent now encompasses going across all of Northern Ireland, which would make and be able to audit against best end-of-life care for those, not to use the WHO definition, dying patients, in terms of, I think that would improve care. Now, it's been looked at by the RPMG, and I don't want to speak for RPMG, but it's unanimous that this would be a good thing to do. And it is very low-hanging fruit. But just to challenge you, Alan, in terms of priorities, I know there's not enough money. I find that surprising because I know through the Barnett formula we get more per head of population than anywhere else in the UK, but there is not enough money. It's where does palliative care sit in your priorities? And that is the fun. We've just heard from the Department of Health there regarding respect. It wasn't a priority, essentially. And that is our recurring theme. Why has nothing happened? Because we are never, ever prioritised. We are not seen as essential. We're seen as some sort of icing on the cake kind of service. And I would challenge you to find a doctor who says that, but that is a general perception, because especially through COVID, the feedback we got through COVID, we were the vital service in terms of COVID, the palliative care community. This is our frustration. Priorities.
Yeah. Michael, do you feel that a 3-year, multi-year budget will bring some benefit?
I don't know anything about the multi-year, but I do know there was 100,000 by the Westminster, which doesn't reach us, so it didn't reach the palliative care community here at all in Northern Ireland. A multi-year budget, I think there needs to be a long-term investment plan rather than have lots of pockets of money given. And I think there needs to be a regional approach to it. And before, simultaneously to that, you need, as I keep reiterating, service specification. So you need to know what the services are and I accurately identify them so you can commission them appropriately.
Chair, is there merit in pursuing what we discussed there with the regional last days individualised care plan with the department?
I mean, I think we can ask questions, but we're doing that's the purpose of the inquiry, is to take these things forward.
I get that, but given an advance of that.
Yeah. I mean, we can have a conversation. I mean, once the evidence is finished. Is that you? Are you finished questioning now?
Yeah.
Okay. So, I mean, we will have a kind of a clean up when you go in terms of what we do following on from this. But I mean, can I just say, I really appreciate you giving up your time. We did spend a lot of time there. We could have spent a lot longer. I mean, I have a list of questions that I could easily have asked and would have liked to have asked. But I mean, we have had excellent evidence, and we have your written submissions, and you know, that has been all useful. Can I just say one thing, just Dr. Dorey, in terms of priorities? I mean, we're not the health minister, and we're not the department. We're the health committee, and we have prioritised this. That's why we're doing this inquiry. So
I really thank you for that.
Not everybody, you're not far down the list with regard to everybody. Certainly from the health committee's perspective, this is a priority, which is why we are taking so long in terms of our inquiry and listening to so many people in terms of evidence. And we hope to be able to produce a report that will give you hope, Dr. McPherson. So thank you very much.
Thank you very much.
So, members, just on the back of that, and I mean, obviously Alan has made a suggestion. Is there anything that we want to do short term or in advance of that in terms of writing to the department? So I'll just allow Alan to come in, and then Diane. Alan, you were making a suggestion that we contact the department in relation to that.
Well, given what we've heard here today, that low-hanging fruit has been the theme and the topic of the day, so I suggest that we do write to the department and ask where this is at.
Okay, fair enough. Dan?
So I'm a little bit confused. Well, maybe I don't know whether I'm confused or not. But anyway, I'll go with this. So we had a letter from Gerard Cassidy, which says, I don't know what you're talking about, sure we are commissioning palliative care beds. But yet we know that so many of the groups here come and say to us there is no legal requirement in terms of palliative care beds. And I was just wondering, should the committee seek a legal view on the Act and on what Mr Cassidy wrote to us, and on something like the Baroness Finlay amendment, which, I mean, as Dr Dory said, isn't perfect, but actually gave, you know, the impetus for the commissioning of beds in England. So it was just really to see if the committee wanted to kind of clarify everything with a legal view.
That's something the Assembly Legal Services could do for us.
Yeah.
Okay, well, I think that's a good suggestion, to be honest with you. I think it's important that we get that correct. Okay, so we've just been given this RPMG survey, so we can read that. So anyway, members, we will take those two actions and come back once we get a response on both of those. So moving on then, so we have a briefing from the Assembly Research Service. Sorry, I should say apologies. I mean, I thought given that we had one cancellation today, I allowed a lot of latitude there. That went on, but it was very, very useful. So apologies. But we're now moving on to the oral briefing on, again, our inquiry from Assembly Research. So can I refer members to page 146, the meeting pack. It contains a research paper on how other countries fund and deliver palliative care. An excellent research paper. So can I welcome Sinead McMurray, Assembly Researcher. Sinead, with 40 minutes. So I'm going to hand over to you. You have a few slides you want to go through and give us some opening remarks.
Well, I think actually positively the first couple of slides have already pretty much been covered so well by the presenters before me, so I'll fly through that pretty quickly. So the purpose of the presentation here today is just to provide an overview of a series of case studies which are in the paper that's in your pack from both international settings and closer to home. So the case studies that I'll be sharing have been highlighted in the literature that is available as examples of how different systems are working to improve quality, integration and value in palliative care. The focus isn't so much on holding up one particular case or model as a solution, but just on drawing out, I suppose, some of the key enablers that support the delivery of palliative care. So just to put the case studies in context, the next slide looks at the wider shifts happening in healthcare systems globally and how that is affecting the delivery of palliative care. So within the global context, health systems are undergoing a significant shift, and often that shift is referred to as the shift left, and that change involves moving care from hospital-centric models out into the community with a stronger focus on prevention and improving population health. And so to support this shift, countries are turning to integrated models of care where health and social care are delivered together, underpinned by local leadership. This shift is also reflected in palliative care, where services are expanding, as has been mentioned previously by the other presenters, beyond end-of-life support care to earlier in the course of life-limiting illnesses, and delivering that care closer to home. So in theory, Northern Ireland should be well positioned to transition to integrated care compared to other regions across the UK and elsewhere, as health and social care services are already structurally integrated. However, it's widely recognised that the system currently as it's configured isn't reaching its full potential, and that's due to all of the areas that have been mentioned: siloed working, fragmented service commissioning and complex funding allocations. So there is a strong commitment, which has obviously been seen here, to palliative care amongst providers, and there's strong community support for palliative care, but a lack of strategic enablers are limiting the capacity to bring that forward. So there are, I suppose, a range of key enablers that have been noted in the literature that support the delivery of palliative care, and some of this has been noted here on this slide. So I suppose the first thing, which has been mentioned already as well, is starting with data. This comes up commonly as both a challenge and an opportunity. So a number of the case studies that are presented, including Wales and Australia, show how good quality data can support better planning, clinical decision making and outcome tracking. Funding obviously has been mentioned too, and that's another major theme. So several of the case studies, such as Portugal, which I'll demonstrate here, and Germany and Sweden, show how more flexible funding models can support coordination and innovation in service delivery. And related to that, has been mentioned as well, is the multi-year contracts, and how that allows time to innovate, to build capacity, and for services, I suppose, to plan in advance. And then related to that, I suppose, is coordination and coordinated care pathways, and that also comes through quite strongly. So integrated care models aim to deliver, I suppose, a more seamless patient journey, and funding models can play a role in that. So as we'll see in Portugal, payment structures support the entire care pathway, not just individual information or individual interventions, which enables the delivery of more coordinated care. So in Northern Ireland, funding, as has been highlighted, is fragmented, short-term and inflexible, makes it harder for services to grow. And there is, as has been noted, limited access to regional or patient-level data to track outcomes, gaps in services. And so as a result, then, there's limited ability to make evidence-based decisions. So the next slide will show how these enablers look in action. And the first one that I'm just going to give an overview of is Portugal. So Portugal has one of Europe's highest rates of chronic kidney disease, which leads to end-stage renal failure without, I suppose, dialysis management. Patients are often older, have complex comorbidities, and they require dialysis sometimes 3 to 4 times a week. So by 2008, the Health Ministry in Portugal had noted that the cost of dialysis care had essentially become unsustainable. Services fragmented between public and private providers. So private providers delivered most of the dialysis through a fee-for-service model, with each session being paid for individually as it was administered. And that, I suppose, offered little incentive for coordination or efficiency. And then meanwhile, the public sector covered all the other aspects of renal care, so lab testing, medications, access surgeries. So in response, I suppose, to that kind of siloed care pathway and the fact that it was becoming simply too costly to sustain, Portugal introduced major reform across their dialysis services. So the system moved to a capitation funding model where private providers were paid an ongoing fixed weekly rate per patient. And that included not just the dialysis services which the private providers had already been providing, but it also included all of the other additional services as well, so the access surgeries, the labs, the medications. And so that led to a more, I suppose, seamless coordinated care pathway which has been delivered by one provider. However, it was under, I suppose, the oversight of the Health Ministry in Portugal. So as part of the model, payment was tied to performance, so reimbursement to the private providers was based on meeting quality indicators, and they were things like treatment outcomes, adherence to care protocols. And for that, data became central, so not only for the clinical monitoring, but also for financial accountability and planning. So because the private providers had greater responsibility and greater oversight of the whole care pathway, they were able to introduce significant changes, as well as being on the back of having a longer term contract with the Health Ministry. So that included centralised procurement, so they were able to buy medicines in bulk and negotiate better rates with the pharmaceutical companies, investment in surgical teams and on-site pharmacies, enhanced IT systems to support auditing, reporting, and then internal care coordination across the clinics. And the result was a more streamlined, I suppose, integrated model of care. And the impact was quite significant. Within 2 years, there was a 10.5% reduction in the total cost per patient. So it dropped from 35 to 30%, or sorry, 30 5,000 to 30,000, and there was a 31% drop in pharmaceutical costs due to the fact that they were able to negotiate prices, and they streamlined the medications, so therefore they were using more generic drugs as opposed to the broad range that were being offered previously in the public sector. And longer term studies demonstrated that there were positive clinical outcomes for the patients as well. So anemia is an associated side effect with dialysis and chronic kidney disease, and the strength of the medication that they were using to treat the anemia dropped by 40%, which indicated that they were better clinically managing the patient's ongoing disease. And also there was a 10-year study, and it tracked patient satisfaction, and patient satisfaction increased over that 10-year period. So I think the point of this case study is not so much the public-private sector, but it's just how packaging the financing and packaging the care pathway in such a way led to a more streamlined experience for the patient, and obviously saved the Ministry of Health money as well, and they were able to more reliably forecast their health expenditure. So the next case study which I'm going to move to is Wales, and this, I suppose the purpose of looking at this one is to show how local collaboration and practical changes working within tight budgets can also deliver meaningful improvement. So this example is from South East Wales, and it looks at how the local health board there tackled persistent challenges in chronic obstructive pulmonary disease and asthma care. So COPD is noted as a life-limiting condition as well, and it's associated with significant hospital admissions and a poor quality of life. So in this case, this health board in South East Wales had the highest hospital admission rates and the highest procedures for COPD and asthma in Wales, yet at the same time they were spending a disproportionately high spend on inhaler therapies, and the strength of the inhaler therapies that they were using were disproportionate in comparison to other countries. So to address the issues, the health board, the health board formed a multidisciplinary group, and so they brought together a range of experts, so clinicians, finance leads, third sector, community groups and patients, and they basically formed a project team to look at why the rates of admissions were so high comparative to other areas. And the team reviewed, I suppose, a wide range of national and local data to better understand prescribing patterns, patient access and variation in service use. And one of the things that was noted in this particular case study was there was the fact that the local team, I suppose, were included within the plans to improve the service made a big difference in terms of it was very unifying and it was central to the success of the project. So that kind of local input and local leadership was very important. So the lack of comprehensive data to actually undertake this work and to look at the service gaps, etc., was noted as a significant stumbling block. But they were so for example, it wasn't always possible to differentiate between asthma and COPD prescribing, which limited the ability then to track outcomes for those patients, but they still were able to highlight some inefficiencies and clear areas for improvement. So, for example, data sources that were available indicated that there was a significant number of patients, COPD patients and asthma patients, who were missing their annual inhaler reviews, despite regular reminders from their GPs. And as a result of this finding, they launched a pilot programme through community pharmacies to proactively identify individuals and provide support and advice at the point of prescription collection. And so that was an example of making use of local services without incurring significant costs. Early audit work also identified a growing number of new drugs and inhaler devices on the market that were causing, sorry, I can see my teams popping up there. Just throw that off. That were causing confusion, I suppose, and inconsistency among patients and professionals, and there was a lack of consistency in prescribing between primary and secondary care. So in response, the team developed a new prescribing strategy. So it simplified the prescribing guidelines and promoted more cost-effective cost-effective device pathways. So the team also addressed poor inhaler technique. So that was an issue that was contributing to suboptimal control of symptoms among patients and was resulting in patients turning up in hospitals. So the team made a strong case for investment, and they secured a multi-year funding programme for a Train the Trainer inhaler technique programme. In other words, so that the people who were actually handing out the inhaler devices were trained properly in how to train patients how to use them. And the team also highlighted and challenged, which is a particular issue that they identified, was the funding structures within the local health board. So they put forward suggestions. It isn't actually clear from the literature whether this was eventually used, but they proposed that any fundings that they made from, say, savings that they made in pharmaceutical areas, that they could reinvest those savings into pulmonary rehab community services. Those pulmonary rehab community services are proven to be evidence-based to actually work and support that initiative to keep people out of hospital. So that was one thing that they noted and they did put forward. Again, I'm not sure whether it was enacted or not, but the outcomes from the work were clear. There was 1.3 million was saved on prescribing over the course of 2 years. The average respiratory cost per item, so per device, was reduced by 9.2% because they brought in those simplified guidelines, and there was consistent guidelines across primary and secondary care. And they also demonstrated improved outcomes for patients, which were harder to identify because they didn't have the data to split out asthma and COPD, but they did notice a reduction in admissions in hospital across both groups. So there were some, I suppose, positive initiatives that came out of relatively low investment. You know, there was obviously the time investment from the team, and there were some investments in terms of the multi-year project for the rollout of the Train the Trainer programme. But by coming together, sharing the data, sharing local knowledge, and sharing, I suppose, responsibility for solving it, it did make a significant change in terms of spending. So the next one that I'm going to present, which is in the paper as well, I'm not going to present all of the case studies that are in the paper because I'd be here for quite a while, but I'm going to prepare, I present some of the ones that I think are probably the most interesting. So this is another example from Wales actually, and it's more about how, I suppose, patient-reported outcomes and better data tracking can result in better individual care and, I suppose, help track more nationally trends and service gaps. So patient-reported outcomes measures, or PROMs, they first emerged from clinical research, but they've become a key part of healthcare data collection more broadly. So they're less concerned with disease-specific measures and more concerned with capturing how people feel about their health and their daily life. So while they're undergoing treatment, so things like, sleep patterns, coping day to day with just general life skills, managing the stairs, those kind of things. So not just clinically how the patient is performing on treatment, but actually how that treatment is impacting them day to day. And so as a result, PROMs are now used not just to support individual care, but they're used to benchmark services, identify gaps in delivery, and help make better decisions at a system level, especially when they're combined with other clinical and population data. So Wales is seen as a leader in this area, and this patient-reported outcome measures are now built into 47 different clinical care pathways. So this example is from Cardiff and Vale University Health Board, and it highlights the role of patient-reported outcome measures, or PROMs, in improving care for people with myeloma. So myeloma is an incurable cancer, and while treatment can stabilise the disease and prolong life, it often comes with high toxicity and significant impact on quality of life during the treatment phase. So the clinical care team that were operating in the Cardiff and Wales Health Board wanted to understand not just whether their treatment was clinically effective, but also whether it was actually helped patients feel better and was maintaining their independence while they were undergoing treatment. So the team were also concerned that patients were underreporting their symptoms, and that has been highlighted in other research, that patients can be fearful that if they report feeling particularly bad on a medication, that they're in some way their care might be compromised or it might be reduced, so they tend to not share in some cases how they're feeling with the clinicians. So to support this, they basically developed a digital PROMS survey that could be completed at the appointment, but separate from, say, sharing it in the consultation with the nurse or the doctor. And it asks questions it asks patients those questions like around sleep, coping at home, feelings of anxiety, social connections, those kind of things. So the results gave clinicians sort of, I suppose, a more rounded picture of how treatment was affecting the patient's day-to-day life and a picture of their care over time. So when the scores, when a patient's scores were consistently low, it triggered a review and a referral to a dedicated quality of life clinic. So a specialist nurse then would work directly with that patient to make changes, hopefully to better support their well-being through the course of their care. And then beyond, I suppose, the individual care level, this PROMS data is now being merged with a national data set on myeloma. And the purpose of that is to bring together information on survival rates, demographics and service use across Wales regionally. And so that can support identifying variations in care, targeting resources and improving national planning, but also feeding the patient view within that. So it's as much about the patient as it is those other metrics. And this is just a quote from, I suppose, the woman who is the clinical lead and responsible for myeloma. So his PROMS helps answer the critical question, is this treatment actually making a difference? If chemotherapy leaves someone too fatigued to enjoy life outside of their home, is it truly beneficial? Without PROMS, we risk overlooking what matters to patients. So on a broader level, this next data, I suppose, is a national palliative care register in Australia, and it's called the Palliative Care Outcomes Collaboration. And it's, I suppose, held up internationally as a gold standard in terms of tracking palliative care outcomes and services nationally. So the Palliative Care Outcomes Collaboration, or known as PCOC, has been running since 2005. It began with 8 pilot sites and it's now stretched to over 220 services. It covers about 60,000 patients annually and it covers all specialist care in hospitals, hospices and the community. So the purposes of in terms of how it works, clinicians record a core set of clinical and patient reported outcomes for every episode of care. That data is submitted into a national portal and then it's analysed twice a year. The services that are participating in the collaboration then receive reports on a 6-monthly basis, and those reports essentially benchmark their service against the other services that are participating in it. So they have national comparisons, I suppose, to compare how poorly or positively they're performing. So I suppose the data for it is used at multiple levels. So it's used at the point of care, and it supports clinical decision making and helps the specific teams that are working with those patients, identify where symptom control or care planning may need to be adjusted. Nationally, it supports policy and treatment guidelines, and it informs research. So it's used for research purposes. And then it also highlights service variation that otherwise might go unnoticed because services have the capacity to benchmark themselves against other services in the area. And there's a learning perspective from that as well. They can learn from each other in terms of best practice. So these sort of, I suppose, palliative care registers, it's a huge undertaking and it's 3 universities, it's funded by government. But those palliative care registries, there is difficulties associated with establishing them in sense of the time and resources and investment that needs to go into establishing them. So they have invested heavily in terms of making that work. So they have technical support on hand and they've trained facilitators who can support the various sites in terms of inputting the data and using the data to its best ability, I suppose, to be able to inform their future work. they have significant IT capacity. So one of the issues with palliative care registers is the interoperability of the system. So some obviously local palliative care services aren't going to have the same level of IT as, say, a bigger hospital or a hospice might. So they provide alternative, I suppose, portals through apps and things that they can upload the data so that everybody can still participate, and you're not just getting I suppose, reflection of some services rather than the overview. So I think so there is key benefits to it. But despite having strong data within Australia, there are still significant challenges in terms of palliative care, so particularly in terms of equity. So the PCOC data actually identified that access to palliative care among lower socioeconomically disadvantaged groups had actually decreased in 10 years. So it was useful in that sense. It was able to notify trends that otherwise may not have been noted. So I suppose and this is what stakeholders in Australia are, I suppose, highlighting as well, is that it's absolutely excellent to have the data at hand, but unless that data results in meaningful action, it's somewhat redundant. So there's I suppose the double edge of, yes, it's fantastic to have data, but it's what you actually do with that data that is the most important aspect of it. So there are another couple of case studies within the paper that highlight various different aspects of those kind of things that may be worth looking at. And I know they mentioned, the guys who were in before me, about advanced care planning. And there is a local example of how that's been set up in Essex. It's called My Care Choice Register. And it's essentially a local database. One of the things that they've highlighted in England in particular is, particularly in integrated care boards, is the lack of data for commissioning palliative care services at home, and I suppose that's similar to the situation that we have here. But this particular data set was established in Essex, and it records patients' advanced care plans within the database, and it's an electronic palliative care coordination system, and Marie Curie have promoted these coordination systems as being useful for patients and family members, because the person's advanced care plan is recorded in that with their wishes, and it can be accessed across all services. So when a patient presents to A&E, the clinicians can access this particular database and see what that person's care plan is. And they've actually built out that database now into a broader dashboard. They've drawn on local data sources, which they've pulled together into one dashboard, I suppose. And they're able to use this to, I suppose, service plan more effectively. So there are a couple of other examples in the paper, but I think just summing up in terms of two themes that kept coming out to us when we were looking at the research is systematically collected data can enhance palliative care, especially for those long-term high burden conditions, that those life-limiting illnesses. But there are lots of considerations to bear in mind, like what data is there already. The King's Fund report from 2023, which looked at that commissioning of palliative care at home in England, one of their recommendations was that oftentimes there is data that is available within the community, it's just not being compiled in the right way and it's not being shared. So almost like taking an inventory of the data that is available and then seeing, is it being used to its full potential? Is there a way that that data can be pulled together using particular analytical tools? And things like supporting staff to participate, because data can just be, and collecting data can just be another added burden on top of a staff member who's already overstretched. So in terms of finding ways to support staff to easily record data. And then the other thing is to actually action that data. So if you're going to ask people to collect data, using that data to encourage long-term buy-in, to actually use the data and show actionable insights from the data. And then I suppose the other thing is funding, and how well-designed funding models can support delivery of efficient and quality care. So a review of integrated care systems in England recommended that in order for the integrated care boards there to reach their full potential, local systems should be given greater flexibility to determine service allocations and to apply the most appropriate funding mechanisms. So basically giving local, I suppose, service providers the power to be able to move funds more freely, and to, I suppose, allow them to trial innovations and support their communities according to local need rather than top-down budgeting, which doesn't necessarily address local need. So they are two, I suppose, just trying to conscious of the time. So that is a whistle-stop tour of what's in the paper. There's obviously more funding, there are more examples there to read through, but if anybody has any questions, I'm happy to answer them.
Thank you very much, Nate. The paper is very good and it does provide really good research. I'm conscious that you're here to answer questions on research, not politics and policies. So you finished on data and funding, obviously very important. You made the point to collecting good data is important, but what you do with it is probably equally as important. So you were in, whenever we were getting the previous evidence, and I mean all of those respondents talked about the lack of data here, or problems with data here, and they also talked about structure, so silos, we don't need them. In terms of your research looking elsewhere with regard to the structure of, going beyond the data and the commissioning, etc., are there more examples of regional, local commissioning or national commissioning, or is there differences in that across the places that you looked at compared to here?
In terms of the data?
Not even beyond data, so collecting data, just the commissioning of the services, so we've 5 trusts here.
Yeah.
As opposed, when you were talking your first example in Portugal, you seem to be indicating that the Department of Health took ownership of it and, things improved. So I'm just wondering, in terms of that aspect of it, if you have anything you want to share with us.
I think what's worth highlighting from the beginning is when, and Grania Creeley has been doing a lot of the research on this as well, there is actually a lack of research generally in terms of palliative care. It was quite difficult to even pull together these case studies. In terms of research around it, the research is still relatively new. I think, interestingly, no one seems to have palliative care figured out in terms of the best way to fund it, the best way to commission it. There are countries that are further along their journey than, I suppose, in terms of developing a comprehensive service, like, say, for example, the Netherlands, Germany. They have stronger palliative care services. But it's hard to say, is that a result of, for example, they have legislation, but they also have stronger care networks, they invest more money, so it's hard to know which bit of it is making the difference and making it a better service. So that is important to bear in mind. And even with, say, the Netherlands and Germany, who look to have a great system, they still have issues with equity, they still have issues with geographic variation, they still have issues with access to specialist care. So there's no one that has it quite figured out. I think what I mentioned before is that the way that countries and regions seem to be moving, because there is this shift left into the community, they're moving towards that sort of integrated care models, which in theory we have here already. But as you say, it's about, that isn't necessarily structured and it hasn't worked the way that it was intended. I have mentioned in the paper that the plan going forward, from what I can see, is that Northern Ireland is progressing integrated care system Northern Ireland, which seems to be a new, I suppose, model similar to the integrated care systems in England, where there will be area integrated partnership boards at a local level that will be responsible for planning and delivering and commissioning services. And I do know that they have done a pilot study of those, of an area integrated partnership board here, and there is a report available on that and how that worked. But in terms of specific examples, no, but there is that general shift towards those models. There's a model referenced in the paper called Optimedis. It's a German model that's an integrated care system as well. But that seems to be the general direction, locally based, giving more autonomy, financial control, and commissioning control to local services, with obviously a regional oversight.
Okay. So nobody has quite figured it out perfectly yet, so they'll all be waiting on our report.
That's it, right. Exactly. And I think even with the legislation, it was interesting, the mention of that. Say the Netherlands and Germany, they have strong legislation in place, and they obviously have more or less 100% funding for hospices. But then Portugal have introduced legislation as well, and that hasn't had the same effect. So it's even hard to say, is legislation on its own going to be enough to change it? Does it need, and in Germany and the Netherlands, say, is it the legislation that's made the difference, or is it all the other stuff as well? It's hard to know.
Good job. Linda?
This is an opinion, so you don't have to answer it. Chair, you've actually covered some of what I was going to ask, and so that's welcome, but it's on the back of what has just been said, you know, around who has figured it out or hasn't figured it out, and whether it's legislation or not. You see, maybe somebody has figured it out, but they haven't implemented it fully. So, and I suppose that goes back to the concerns that were raised in the previous presentation, and, you know, will we put together a great report with great recommendations that would actually fix everything there is to be fixed in palliative care, but if it's actually not taken on board and implemented. So, and you referenced it there at the very end of your presentation, and it was also referenced by either Matt or Alan, I'm not sure which, around, you know, this is a top-down, but actually, is it and should it be a bottom-up, which is what we're doing, where we're listening to what the people who use the service, who deliver the service, are saying, and we're coming up with all of the answers. But how do we then get it implemented? So do you think there are possibly places that have it figured out but just haven't? That's political decision, that's ministerial decision.
Yeah, I mean, I suppose just from that perspective, that if we're looking at that, say, integrated care system Northern Ireland, that structure that they have in place, there is regional oversight. So those kind of things like commissioning services, standards, they would come at a regional level, and then that bottom up would come from the local level. So local service providers would know what their particular, I suppose, patient group or whoever it might be, they would have the best information in terms of what these people need. So there would be regional oversight, but then those local area integration partnership boards would be given, more, I suppose, autonomy. And then that ties into the funding as well. If there's more local, flexible funding models rather than a block grant that's given once a year, if the local areas have more, I suppose, capacity to move funding around, like that example in Wales where they move funding, where their plan was to say move funding from prescribing savings and move it into pulmonary rehab. If there's more flexibility at that level, that can help. But I think that regional oversight is important because it provides a structure and a standard, and then it's, I suppose, the combination of the two meeting in the middle. At least that's the theory behind the integrated care system.
I suppose that just comes from if you simplify it down to one issue, if you look at the likes of the DNR and the failure after all the years we've been talking about it to address it. What is the point in asking people to give us information and to tell us how we can fix things if there isn't an actual political will within the department and the ministry to fix it? It's a wee bit frustrating.
Sinead, thank you very much. Appreciate your work and coming before us today. Thank you.
Cheers, thank you.
Okay, members, going to move on to item number 7, correspondence. So there's obviously, because of the Easter recess, there's quite a bit of correspondence. I'm going to go through some of them. I'm sure members will want to comment on other aspects of it, and then we'll come to an agreement on where we go. So the clerk has provided suggested actions in terms of the letter on respite services and short breaks. Can I just refer everybody to page 218, and that contains a departmental response to issues that we raised, or that were raised at the meeting on the 13th of March around respite and short break services. So I don't know if members have any comments on that, or if you want to, certainly want to forward a copy of the correspondence to the Children's Law Centre, just for their views. Are people content with that?
Yeah.
You're forwarding?
Yeah,
Oh,
I'm
yeah.
suggesting we
that's-
forward it.
Yeah, that's totally fine.
Okay, and then another one just for mentioning, so update on the cytology review. So can I refer members to page 334, and that contains a further update on the cytology screening review. So are members content that we forward a copy of this correspondence to Ladies with Letters, and that departmental officials are invited to provide an oral briefing to the committee on the outcome of the review and answer questions on the matter? Dan.
Sorry. So, I mean, I think the letter is strange in its the way it says. So it tells us that we cannot give you individual screener data because that would actually identify the individual screeners. But yet the Royal College report into the issues in the Southern Trust actually did give us individual screener data. So I'm not understanding why the Belfast Trust cannot do that or will not do that. And it says it is going to then pull up other data, which will be extracted, validated, and so on. I do think that we need to actually ask, why can one trust for a Royal College report actually provide that individual screener data, but the other trusts can't? And I'm not being pedantic about this. This is really, really important that we understand what has been going on in this screening programme. And I suppose the other one is, I spoke to Keith briefly this morning about it, that we had asked for the work programme that the UK Accreditation Service had left with the Belfast Trust in order to then further their accreditation programme. We haven't got that information yet, or do they? Is this a reply that they think will give us that? I'm not sure. Just where's that?
Just to say, we would expect a response to the questions that we raised. I think it was at the last meeting before Easter,
yeah.
So it was. So
Yeah.
no, this response is relating to previous.
Okay. And my last thing is that I don't think I mentioned this in the previous request for information from the Trust. We actually were told that this contract was awarded to the Belfast Trust, even though the working groups set up to sort of say how the regional service should work, actually recommended it being split over 2 sites. And there were already 2 trusts, the Northern and the Western Trust, who were accredited for HPV screening, and the Belfast Trust got it when they didn't have an appropriate lab facility and they didn't have accreditation, but the Western and Northern had. The letter previous told us that they had carried a review into how the contract was awarded. Do we know who sat on the review panel, or was it simply the Public Health Agency marking its own homework? Because it is quite serious that this situation actually led to 2 senior clinicians involved in the programme resigning. And just so that we know who sat on that review panel, and was it the same people, or was it an external review of how that contract was awarded?
Wanda?
To be fair, Diane has covered it extensively. I think that the issues that I would want to raise, I think we should invite, in the letter that we send the Ladies with Letters, we should invite them to reply to us with any commentary on the response as well, in case there are additional things. But I think you've probably covered quite a bit of it. So
we're going to send a letter to Ladies with Letters, ask them to come back to us with their views. We also, we've got this response, we're waiting another response. We will send off some of these points, and we're inviting the officials to brief us. So that should cover.
We should probably not have the briefing until we get. I mean, it's up to you, Dan, but I think that unless they're going to give us this detail at the briefing, like to have the briefing, then get a response back to some of this, and then fill with more questions, I think would be
Well, I mean, they should be able to. I mean, we asked the original set of questions well before Easter.
You know what we're going to ask.
So it would be like they should be coming back to us any day now in that, and it's what we're asking now is not that much more knowledge. So they should be able to come back relatively quick, and then we will hear from them in relation to all of the different reviews that have been going on. But I'd like them to come back even in writing around the specific questions that we're asking. I do think women in Northern Ireland deserve a cervical cancer screening programme that they can have complete and utter faith in. And I want every woman to know that it's safe and that they should go and use it to save their own lives, and it's really important. But I do think it's also important that this committee asks those questions.
Yep. Okay, so next one for pointing out. Oh, sorry, Danny.
Sorry, Chair, can I go back just to 7.3, just to the letter from the department about community pharmacies?
Yes.
I find it astounding reading that letter that it conflicts absolutely with everything that we heard from CP&I and pharmacists, and from what I'm hearing from pharmacists on the ground. It absolutely black and white, saying that a small number of contractors had chosen to cancel their direct debits. And that's an act of desperation. That's something that you do when you cannot, financially unsustainable, you cannot go any further. But the wholesalers had advised that invoices were generally paid on time. I think the suggestion here is that we forward this to CP&I just for their comments on this. Is that correct?
Yeah.
Yep. Could we also ask the department just for some figures on that? How many people were having to cancel their direct debits, and what percentage of people didn't pay their bills on time? And given that there's no mention of clawback at all in this, and it's a major issue that was raised by Community Pharmacy and I find it absolutely astounding that a sector that is key, according to the Minister, is financially unsustainable and is described in these terms.
My apologies, I wasn't really going through them in order there. I was going to come back to that one myself, so thank you for raising that. I mean, I think the letter, it didn't really answer some of the questions that we asked, particularly about whether the opening envelope was negotiated with CP&I. There's a lot of differences in regard to what we're hearing from the local community pharmacists and from the department. So I do think, first of all, we should send the department's letter to CP&I, get their response, because they will be able to tell us their view on it. But we should certainly raise again those issues that you have raised, if everybody is content that we do that. Okay. Thank you. So what one other, I say, I'm potentially not going through this in order, which is my fault, but the other thing I just wanted to raise was the Royal College of Psychiatrists had written to flag up a workforce crisis, and they've requested a meeting with me as the committee chair. So if everybody's content, I'll meet them and report back what the issues are. Okay. And Clerk, can I ask you, do we need to, are people happy? Can I just ask if people are happy with the rest of the suggestions, or is...
Yes, just...
Okay. Go ahead, Diane.
So 7.22, the House of Lords Scrutiny Committee on the Tobacco and Vapes Bill. Now, I obviously will declare an interest. My husband is a member of the House of Lords Scrutiny Committee, but I didn't know this letter was coming. I had no idea about it. So just that we're kept up to date with that, because it's quite an important piece of legislation. The government has said that this, and told us in agreeing the LCM that this was applicable to Northern Ireland. This letter actually quotes the Tobacco Products Directive as being cited in Annex 2 of the Windsor Framework, and therefore applicable to Northern Ireland. So is there a conflict, and what is the outcome of that in terms of the bill applying here? They say they're writing obviously to the Minister, and they've just shared that letter, but it's just important that we see the outcome of that. presume we will, as a matter of course.
Normally on these letters where we're copied in on the EU, we will get copied into any response that goes back to the chair of that committee. So it is. So they'll be copied in the. I think there's ourselves, and I think there might have been a couple of other. The chair of the Northern Ireland Affairs Committee was copied in as well. Yeah. So it is. So any response will come back, and we'll get copied into that as well.
Yeah, that's fine. Thank you.
Okay, just another thing, because it's in the box for discussion, is at 7.9 the response in relation to the Southwest Acute Hospital. So, I mean, they have responded to us, but they haven't really answered our questions in relation to giving us the full. I'm confused now whether it's data or data just after the previous presentation, but I'm going to use data. So, I mean, I just think, I mean, we ask for specific data and figures, and we haven't really got that in the response. So, I mean, I would be keen that we maybe go back to them and ask them just to particularly pay focus to the questions we've asked and try and answer them. Does anybody have any commentary in relation to that?
No, but I agree.
Okay.
We need the information.
Okay, thank you. So,
Sorry, Danny. And again, just on two quick issues, just with the cytology issue, could we ask just to get a firm date to see when they will be coming back to the committee after the report is out? And on the second one, just on the respite issue, now obviously there's quite a lot of, I think it's outlined by trust, and there's quite a lot of commitments within that. Now, given that they are spaced out quite long in distance, could we get regular updates just on making sure that those commitments are upheld?
Just to say, Chair, we had agreed that we would request regular updates. So our first update is due to be at the end of June. It's going to be a written update. And then our update in October will be an oral briefing update. So in their letter, the department have agreed to that schedule. So they have. So our first update will come at the end of June.
Those commitments that they have outlined will be updated on the progress of all of those? Yeah, Grant, thank you.
Okay, I mean, the other thing then, I suppose, just for highlighting, is the BMA issue and the contract negotiations with the department. Yeah. I mean, I know I met with them over the, can't remember, I think it must have been over the Easter recess. I presume they met with other political parties. So, I mean, this is a very concerning issue with regard to the ongoing negotiations. So, I mean, the suggestion is that we request copies of replies to the BMA from the Minister. I think we should do that, and then, I mean, maybe we should wait to that, but I do think we should perhaps alert the Minister to the serious concerns that the committee has about the issue, and that all efforts are made to resolve them ongoing contract negotiations.
Yeah.
Okay, so everybody's content then with the other suggested actions, most of which are noting. Yeah. Okay, forward work programme, members, that's at tab 8 of the draft forward work programme. Next week's committee meeting, just it's important to mention, it's going to be held at the Fire and Rescue Services Learning and Development Centre in Cookstown. So we have a tour of the facility before the meeting. Committee is to meet with representatives of the centre at 12:30, and lunch will be available on site. We will then have a tour of this facility before the formal committee meeting, which will take place on site at 2:15. Can I just again emphasise, we need a quorum of 5, and you know, at our last outside meeting that potentially was a struggle. So, you know, it's important that everybody alert. I mean, we want full attendance, but if anybody isn't able to attend, can they let the staff know, and let them know if they're going to be there at 12:30 for the lunch and the tour. And the other thing, it was remiss of me, I meant to say it under Chair's business. I'm just going to say it now because it's the first committee meeting since the wildfires prior to Easter. I mean, I think we should put on record our thanks to the Fire and Rescue Service for the sterling work. I mean, we'll do it next week when we're there, but I think it's important in this forum that we put on record this committee's thanks to them for the work that they did under very dangerous and challenging circumstances.
Sure, I'll not be able to attend that next week where there's a policing board meeting, and that may affect a couple of other members of the committee. That'll be just a priority which they choose to go to. But so,
okay. Linda, were you going to say something
Yeah, I am on the policing board as well, but I always ask for permission out of this
there? Okay.
on full board days, and I'm going to try and, because I missed the last day that you went on, I would like to be there.
It doesn't mean to say we can't go ahead with the meeting properly unless we have a quorum, so we do need that. So
I do intend to try to be there, but I have a VE Day ceremony that I must go to. So I'm maybe a little bit late, but I will try to be there.
good job. Okay, so any other business? None? Linda, go ahead.
Sorry, you tried your best to get away with there. I had a couple of things that actually have been covered today, which I don't have to raise. But could we maybe consider doing, and doesn't need to be done next week or in the next couple of weeks, but an informal meeting with the Children's Reimagine Collective. I'm just conscious that the chair probably hasn't had much of an opportunity to engage. I know that they probably, if they haven't already, they will be reaching out to you for a meeting. But rather than just do that, because it's been a while and I don't see anything coming forward in terms of changes as a result of Ray Jones' report. And that was a massive report. It was an amazing report. There was an awful lot of work put into it, and the engagement with every single element of children's services was outstanding, probably second to none in any review that's ever been done. And I don't see anything that has actually come out of it in terms of from the department that's concerning me. So I would like if we could do an informal meeting with them.
Okay.
I've also had a request from some nurses who are involved in prison nursing, and if we could set up an informal meeting with them, and I can ask them just to get in touch with the clerk.
Grand job.
If possible.
Attempt. Okay, next meeting, as we said, next Thursday, Fire and Rescue and Learning Centre at 2:30 p.m. The meeting starts.
Oh, that gives me
Sorry,
grace.
2:15.
Sorry, 2:15. We've moved. With 2:15. But the lunch is at 12:30 on the tour, so.
I'm going to miss that. So.
Okay, thank you all. Thank you.
Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound.